Hello, Bhushan. In a minute, so every audience speakers requested 1-2 minutes. That's why I stopped.
थल्ले रख दे ऊपर रख दे जिथे मर्जी अच्छा हुन आ देखा म्यूट है कि नहीं म्यूट लिखिया होया था
क्रॉस में जाओ
नहीं
सर कैन वी ब्रॉडकास्ट इट
मेरी आवाज जा रही है
Are we ready?
Yes sir, ready.
Okay.
maybe another minute.
Okay. Can you give me my second mobile? मैं पूछना में बुला ला ठीक है I'm just about to call the admin. We are live now, and we start. I share my screen or Nabu? Hello. Okay, start. Okay.
Yes,
Hello. We are live now, and good morning to all and everyone. And thank you for sparing a Sunday morning first. Let me introduce our honorable guest speakers. Dr. Mohan Rajan, Professor Mohan Rajan, more than above, a very good friend, always ready to share his ideas, adventures, and perfect carry home messages with the audience. He is one man who's performed more than 150,000 surgeries. Proud of you, Mohan.
Thank you.
And taught cataract and phacoemulsification to many of us. He has, to his credit, more than 6,000 vitreoretinal surgeries. Another feather, Mohan.
Thank you.
He has many books to his credit, many teaching lessons and teaching seminars all over the world. I request Dr. Mohan to share his screen, begin with his topic, a never-ending series he has with them to show us. Welcome, Mohan.
Can I share my screen now?
Oh, yes. Oh, yes.
Okay. Are you able to see my screen?
Oh, yes, very well.
Okay. Good morning, friends. Let me at the outset thank Dr. Dhami, Dhami Eye Care, and Ludhiana Ophthalmological Society for this wonderful honor and opportunity here. I'm going to talk to you in the next 15 minutes about 3 different case scenarios. The first one on nucleus drop, the second one on subluxated cataract, and third one something to do with the IOL implantation. So with some clear take-home messages as well. So let me go through that. First, the nucleus drop, as you know, is a nightmare for phacosurgeons. Incidence is 1.1%, but can happen to anybody, whether it's a novice or a experienced phacosurgeon. These are the predisposing factors: posterior polar cataracts, hydrorupture when there is a small rhexis, and capsular rhexis tear, posterior capsular rent. All these can predispose to nucleus drop. Let's go through these videos now. You're able to see these videos now?
Oh yes,
Okay.
quite clear.
It's a very brown cataract. Can you see that? My assistant puts heavy molecular weight viscoelastic on the cornea and pushes the nucleus into the vitreous cavity. It's gone straight away. Only thing is, when you have a nucleus drop like this, don't chase with the phaco probe. That is one important thing. You can see here another patient with the posterior polar cataract, and it's gone all the way down. So once it's gone all the way down, you need to go and do a pars plana vitrectomy. That's what I did, because I do both vitreous surgery as well as cataract surgery. And I remove the cortex in the anterior segment and then go in and do the complete vitrectomy and make the nucleus mobile. I use a sleeveless phaco tip, just like a fragmentome, and try to, this is a video, old video, you can see that this is a posterior polar cataract, fairly soft cataract, soft nucleus as well. I bring it up and support that with the endo illuminator and try to emulsify that in the anterior chamber, and got away because the capsulorex is intact. I was able to put a 3-piece lens on the sulcus and the patient did very well. Okay, this another patient you can see here. Okay, when you have a problem like this, or a nucleus, this thing, PCR, okay, can you see the nucleus is going inside, and only thing is, when you have a problem of a PC chair, do not pull out. If you pull out, this is what will happen. If you pull out, what will happen, more vitreous will start coming into the anterior chamber, and the nucleus will start sinking. As you saw in this picture, the nucleus started sinking into the vitreous cavity, and then I did a bimanual vitrectomy. Always remove the vitreous first, and then subsequently remove the cortex. Don't be in a hurry to remove the cortex, and pray to God the nucleus will come up. Okay, and then you support that with that with the irrigation handpiece. Always, when you have a PC tear, go bimanual. That is, separate the irrigation from the aspiration. This patient also did very well. So this is another patient you can see here. The nucleus is gone, but it's still there in the anterior vitreous phase or in the pupillary area. I do what is called anterior assisted levitation, or AL. You can see this is one of the patients who had a cardiomyopathy, an old patient, and she was having an hypermature cataract, and I did an anterior assisted levitation and brought the nucleus up, and then of course the vitreous has to be taken care by means of the tricot, do a bimanual vitrectomy, and this patient, I put an anterior chamber IOL. The sizing of the IOL is very, very important in these patients. You can see this is a post-operative picture with a 6/9 vision. There's another patient, can see again the nucleus is there, but it's not gone into the vitreous cavity. It's there in the pupillary area. I go through the pars plana and lift the nucleus up. This is called the posterior assisted levitation. Posterior assisted levitation can also be done. You can see there's another patient. I have to go through the pars plana. I introduce a rod there and bring the nucleus up. Okay, this can also be done. Only thing is, please don't do it in young patients and high myopes, because you're going through the vitreous base. And all these patients, please dilate the patients post-operatively and make sure that you examine, because they are all prone for retinal breaks and retinal detachment as well. So now let's go through the next video, and this is a patient, you can see here. Subluxated cataract. A CPR has been inserted there, and we're going ahead with the, I'm sorry, the music is a little loud there. I'll try to reduce the music. I start from the beginning. This is a patient who is a one-night patient, my anatomy professor.
Sir, panelist. Voice man.
Yeah, this is a traumatic subluxated cataract, nuclear sclerosis, fairly brown cataract, traumatic mydriasis as well.
आप panelist best है.
Yes, sir.
ये बराबर तो सर देख रहे हैं.
And you can see that this particular patient, and you can see the cataract is quite dense as well. And you can see the subluxation inferiorly where the arrow is shown. I'm doing a rhexis with the trypan blue. Fairly good rhexis. You know, it's a fairly dense cataract. The other eye is ambulopic. I put a CTR in the beginning itself because I want to make sure there is a circumferential stability for this lens. And then go ahead with the phacoemulsification. I always use Stellaris machine for these brown cataracts. As I am chopping the cataract, I found that the lens is very wobbly. Then I put iris hooks to stabilize the capsular bag. I want that radial stability as well. And then go ahead with the phacoemulsification. So far, so good. Everything is going on very well. I can see that I'm able to do this thing. I introduce viscoat into the anterior chamber to make sure my cornea is well protected. Then again injecting viscoelastic like viscoat or hyalon through the side port before I come out of the eye. Look at this lower left iris hooks very carefully. As you know, when the CTR is there, you need to go circumferentially. It's very difficult to remove the cortex. As you saw that, and went ahead and did this thing. You can see that this rhexis has stone there, the iris hooks are stone there. The first mistake I did was to use the iris hooks for the capsular bag. The second mistake is to keep the iris hooks for a long time. I can see that the tear has gone to the posterior segment and there was a vitreous loss as well. So I thought I'll put a MA60 lens, a multi-piece lens on the sulcus. There is a small tear which is there subincisionally. You can see that I put tricot, preservative-free tricot, diluted. You can do the vitrectomy through the anterior limbal route, but I preferred in this patient the past planar route. I put a trocar and cannula into the posterior segment. This has been advocated by Abhay Vasudha, as you all know, wherein I do a vitrectomy with a 23 gauge trocar and cannula, and the cutting irrigation is there in the anterior chamber, wherein I remove the vitreous from behind. This is an animation which shows that vitreous, how it is being removed, and makes the life much easier. And this is the way I do the vitrectomy. You can see the vitreous is completely gone. The lens is quite stable in the sulcus. Of course, the CTR is there in the bag. I left the CTR there because I just wanted to make sure that when I remove the CTR, there's no problem while removing the bag, making sure that I didn't want to disturb the bag as well. Being a traumatic mydriasis, I tried to do a pupilloplasty, but I failed in that because I couldn't get the pupil down. And that is the end of the surgery, and the patient had 6/9 vision. I always suture all the wounds when I have a PC tear. You can see here, this is another patient with the microspherophakia. Again, a one-night patient, young individual, the other eye lost due to glaucoma. You can see there is a universal zonulopathy in microspherophakia. So I put the CTR, the lens is relatively soft. Again, I'm using the iris hooks for the capsular bag. If you have capsular hooks, that's probably the best because the rest on the equator. And then I go ahead and put a single piece lens. The lens itself is cataract is very soft. And as I'm doing the irrigation aspiration, notice that when I come out, the lens starts decentering. There is a vitreous which is coming out through the zonules there. And what I did was I immediately made two scleral flaps. I'm not sure whether it's the right method, but that's what I thought. Okay, I removed it because this lens is not going to be stable. I removed the lens, I removed the capsular bag, I did the anterior vitrectomy, and then put a multi-piece lens, MA60 lens. Since I've already extended the incision, I went ahead and exteriorized the haptic and glued it, and the patient had 6/9 vision and it's about 3 years follow-up and doing pretty well. So this to show you how we have to overcome the situation. Now, I have another patient, 24-year-old female, traumatic cataract, traumatic mydriasis, zonular dialysis, hydrodialysis, macular scar, preoperative vision 3/60. I always do femto for these patients because I have access to femto. Makes easier in this subluxated, in this complex situation. You can see the inferior zonular weakness there. And as you know, this traumatic cataracts, the zonular weakness, zonulopathy is not progressive. So the cataract itself are relatively soft. And you can see here that I'm doing a fairly good cortical wash-up, injecting viscoelastic every time I come out of the eye. There's a traumatic mydriasis, you can see infranasally. There is also an hydrodialysis as well. I put the CTR, I put the Technis lens in the bag, and then go ahead and do the pupilloplasty. Because as a patient had traumatic mydriasis, I might want to make sure that we got the pupil down, the single pass 4th row pupilloplasty, make the stab incision, and then go with the 10O proline suture and engage the proximal and the distal iris as well, and then try to do what is called the 4th row pupilloplasty, which has been advocated by Amar Agarwal. Very simple, easy technique. I do it in multiple quadrants to make the pupil, because the pupil is a traumatic mydriasis is dilated. So to get the pupil down, I do it in 2 or 3 places. So the pupil, so the Purkinje images are right in the center, and at the and making sure the pupil is also centered and round, not round to a certain extent, smaller as well, so that the glare is also taken care, the contrast sensitivity improves, and surprisingly the patient's vision improved also to 6/18 postoperatively because of the the macular scar, they improve further. The hydrodialysis was inferior, infranasally. Once I did the pupilloplasty, the hydrodialysis became small. I thought I'll leave it like that because the iris was little fragile there and it would make the life easier. Go on to the next one, that is the IOL antics. You know, this is a very common problem wherein the cartridge, the haptic can get caught in the cartridge. And this is actually a nightmarish situation, especially when you have the micro injectors or the medicinal injectors. Sometimes the haptic can get caught. If you try to pull the haptic out, the haptic will get fractured. As happened in this case, I had to extend the incision. This is an Envista lens which got caught. And then I put another lens as well in this patient and got away with this. Of course, I had to, because I extend the incision, I had to suture this technique, suture this, this thing. Another patient you can see here, I'm putting an in-focus lens, a VVIP patient. Again, you can see that the trailing haptic gets caught into the cartridge. What happens is that the cartridge, there is a silicone plunger there, and the cartridge, the haptic gets caught. If we try to pull it out, it will get broken. So what I do is what is called a simple called ocular episotomy. I take a 11 blade and open up the cartridge. Once you open up the cartridge, the space is there, and slowly you can pull that haptic out without deforming the haptic, and you can go ahead and put the same lens into the bag without any problem. So these are the different situations. As far as the worst case scenarios I want to show, I would like to thank the LOS and also Dr. Dhami for the wonderful opportunity and the patient attention as well. Thank you very much. If you have any questions, I would like to take it.
Thank you, Mohan. Really, as always, very extendingly explained and tips to carry home, and what meticulous surgical procedures you have really gone through your worst case scenarios to put them back into line. We have been followed by a lot of people on Facebook, and there were hundreds of likes while you were presenting your videos.
Thank you very
There
much.
were,
Thank you very much, Dhami.
there were some questions.
Yes.
Once you mentioned, it was a very big tip that what colored tip injectors really break. Were the greens, were the blues?
Usually
remember?
the greens.
Usually the greens.
The greens,
And-
the greens are the ones where they can get caught between the haptic and the silicon plunger, and you have to be a little careful with that.
And probably the episiotomy procedure was excellent. And
It's
a
very
tip
simple
for all.
procedure. We would try to pull it out, then what will happen is the haptic will break, and you have to extend the incision and pull out the lens, and makes the life a little very messy as well. So this is a very simple thing wherein you just have to be a little patient and open it up. As I told you, it requires only 11 blade for that, and you can do that very, very meticulously.
Secondly, you did have a trouble while pushing RS hooks. There's a question that how really you managed. You are an excellent surgeon. Could anyone pre-operatively think that I'm going to lose this in my capsular hooks? A little tip on that.
I would suggest that you use capsular hooks for the capsular bag,
Okay.
and iris hooks for the iris. Okay, that is my take-home message. I just want to show you that you should not do the same mistakes as I'm doing. Please understand, this iris hooks rest on the capsular rhexis margin, and if you're going to use iris hooks, don't keep too much of traction for too long a time. Once you remove the cataract, just remove the iris hooks. You don't require the iris hooks anymore. Okay? But please understand that the capsular hooks are much more better for the capsular back stability because it rests on the equator. There is no traction on the capsular rhexis margin. You saw in the first case wherein I did a very hard brown cataract, I kept that iris hooks for a long time. Okay? During the IA, I could have just removed that iris hook. And the lower one, the iris hook gave way, and the rhexis tear extended back into the posterior capsule, and there was a vitreous loss. Don't do that. If you have access to capsular hooks, that is probably the best. The Shanks modification of the capsular hooks are there, wherein it's not very long also, so it doesn't prevent even if you have a CTR, it doesn't prevent you from removing the cortex very easily. So that's.
And another question was, if all this has to be done intraoperatively, once you're into doing phaco, any tip to apply capsular hooks or RX hooks once you are doing surgery? You're not planned for it.
Yes. See, please understand, putting the iris hooks on the capsular bag once you start the surgery is more difficult. Okay, so you need to have a good microscope, and you need to make sure that your capsular rhexis is having trypan blue. Okay, so please understand that whenever you have a subluxated cataract, please use trypan blue, because you want to know exactly where your capsular rhexis margin is. Okay, don't use too much of trypan blue. Use the trypan blue under air. That will tamponade and make sure that the trypan blue stains only the anterior capsule. Because there can be zonular dialysis, sometimes the trypan blue can go, if you use excess trypan blue and keep it for a longer time, the trypan blue can go across the zonules into the anterior vitreous, and instead of a red glow, you will have a blue glow and make life difficult for you during surgery. Please understand this concept. Just keep the trypan blue for a few seconds and underneath the air bubble so that it stains only the anterior capsule. And you want to know exactly when you're doing the capsular rhexis, exactly want to know when you're putting the iris hooks or the capsular hooks where the capsular rhexis margin is. So trypan blue is the key for this.
Now, any panelists who would like to add any questions to?
Anything from Kamal? I would like to.
Sir, I think
from
nobody
Indra
can better
Mohan.
you what you just described. Whatever you described is perfect. The only thing I would say is I, for once in my last track record of 20 years, I've just used once. I've used a capsular tension ring. I've always used an endocapsular ring and works well. The trick is not to pull too hard, which you described.
Yes.
And another trick is that each time you pull one hook, put another hook on the opposite side, but don't tighten them. Then put two on the other side and then titrate the tightness one by one. The way you fix a nut bolt on a stepney. You don't tighten one nut at the time. You
Absolutely.
tighten one and then tighten the opposite one. Then tighten this one and then tighten the opposite one. So if you do that, the CTR capsular tension ring can be put very easily along with this. And, and even an iris hook works best in my hands. But yes, for a beginner, a word of caution, whenever you do the iris hook, make sure the one on the nasal side is not exactly on the medial canthus, because if you're doing a temporal phaco, the hook will go and hit the nose bridge and it tends to bend down as the eye rotates medially, and that's the time it can actually tear it. So make sure that the hook is not exactly on the nasal side. It is bifurcated approximately somewhere around 11 o'clock and somewhere around 7 o'clock. Then it works best.
Yeah. So what I think the Dhami Kamal has given the message very clearly. Please understand that if you're going to do, even for the iris, when you're using the iris hooks, don't give too much of traction. More importantly, when you're using for the capsule, don't give traction at all. Just keep the capsular bag, slightly stretched, not too much stretch. If you have too much stretch, then the possibility of a rectus tear is there. So you go ahead with the iris hook. I've been using iris hooks for so many years before I switch over to the capsular hooks.
Excellent surgeries, Dr. Mohan.
Thank you, sir.
Congratulations. In fact, these are all difficult cases, and you can expect some trouble during surgery in these kind of situations, especially these subluxated cataracts and microspherophakia and all. I usually, like, it's just one suggestion. What I usually do is I just put a 25 gauge or a 23 gauge pars plana cannula in the infratemporal quadrant and just plug it in case it is required for either irrigation or for doing some small maneuvers during surgery, or if we are caught in a situation where we need to go ahead with a VR surgery and convert the surgery. So that's about it. Otherwise, you are an excellent surgeon, and these are the exceptional cases which you have presented.
Thank you, Dinesh, for the nice comments. See, what I see, the many anterior segment surgeons are a little apprehensive in putting a trocar and cannula into the vitreous cavity because they are not very familiar. So it's not easy to put a trocar and cannula, especially when you have hypotony. Please understand that you need to fill the globe with the viscoelastic and then probably suture the main wound, and then before you put a trocar and cannula, measure about 3.5 millimeters in the limbus and put a trocar cannula, go in an angled way. If you're not able to do that, if you're not confident of doing that, because sometimes putting a trocar and cannula can be very dangerous, especially when you're not experienced. So you can go ahead and do an anterior vitrectomy also. There's no problem at all. Limbal vitrectomy. Only thing is, when you're doing a limbal vitrectomy, anterior vitrectomy, use tricot, preservative-free, diluted, and also separate the irrigation from the cutter. Okay? Have an irrigation anterior chamber maintainer and separate the irrigation from the cutter. You can go ahead and do that. And it's not necessary that you should do pars plana, because I'm doing both anterior and posterior thing. But if you want to do the trocar and cannula, it's not very difficult, but it is maybe for many anterior segment surgeons, whenever I present this in the conference, sir, very difficult for me to put a trocar and cannula. Okay? So that is a message.
Actually, sir, that's why I'm saying before the start of surgery, I just put a trocar and cannula and put a plug on it and keep it there.
Yes, sir, because you are doing vitreous surgery as well. I'm talking about anterior segment surgeons, Dinesh. That is the reason why this has to be practical for everybody. That is the main objective.
Yeah, that's true.
Abhinav, there's a question for you.
Mohan, very nice presentation. One thing I wanted to know was, how to hook a nucleus when it is lying on the anterior vitreous. Hooking the nucleus is sometimes a very big problem. How to get it done?
No. Please understand, if the nucleus is there in the pupillary area in the anterior vitreous, okay, it's not gone in, okay. I've been very clear. If it's gone in, it disappeared and gone into the vitreous cavity, don't chase it, okay. Don't chase it. If it's there in the vitreous cavity, you can do the anterior assisted levitation or the posterior assisted levitation, okay. Only thing is, you need to make sure that you take care of all the protocols, okay. And also make sure that you remove the vitreous completely. Make sure that you use tricot. You can either do a pars plana vitrectomy, pars plana approach, or limbal vitrectomy, as I mentioned earlier. And only thing is, you need to make sure that the nucleus is there in the anterior vitreous. You're able to see the nucleus. Then you can do anterior levitation or posterior levitation. The nucleus has to be in toto. Okay. If you have only half the nucleus or quarter nucleus lying in that, you cannot do all or pal. Okay, the nucleus has to be in toto in one block. Then only it will be easier for you to do the anterior levitation or the posterior levitation. Don't do it in young patients or high myopes. Please understand, we are going through the vitreous base, and you have possibility of retinal breaks and retinal detachment in the future.
So Mohan sir, there's a question for you. When
Yes.
do you plan to use a CTR, or before the lens extraction, or after that in a subluxation case?
Yeah, I plan. See, depending on the subluxation. For example, you can do it as early as you want, or as late as you can. Okay, I try to put the CTR as much as possible as late as I want to. Okay, I go ahead and do the Filco supporting the bag, the capsular hooks or the iris hooks. Go ahead and try to put the CTR at the end normally. Okay. In some patients, for example, the patient I showed just now, the brown cataract, I didn't want to it's a one-night patient. I didn't want to take any chance. So I put the CTR in the beginning because I wanted both circumferential and radial stability as well. So depending on the case, but I would like to push it as much as possible.
Are we done, Abhinav?
Dr. Mohan, yes, Dr. Dhami, I would like to just point out some.
Sure, please, sure.
Yes, Dr. Mohan, yes, we really enjoyed your videos, and definitely we always enjoy your videos, maybe any form of that, as you are an excellent surgeon. So what I was seeing, you have put in stitches in most of the cases where you remove the lens or maybe you enlarge the incision. So to remove the lens, once you have put in, you have to enlarge the incision to 2.8, maybe 3 or 3.2 millimeter, and you can just take out this lens without even cutting it. So for that, I don't think we should be putting in stitches. What you can do is you can put in a supraincisional pocket beforehand. Once you just hydrate it, wound closes by itself. Or if you have to enlarge the incision slightly more, just tighten the eye, put in another supraincisional pocket to this side that you are going to enlarge the incision. Probably again, it will be just watertight incision or in the end. If we can do that, we can avoid putting sutures. Can we?
Yes, sir. I would tend to disagree with you, sir, because whenever there is a PC tear and the vitreous loss, please understand the incidence of endophthalmitis increases by 4 to 5 times. Please understand this concept, sir. So I would prefer, because I want absolutely a watertight incision. So that is, of course, supra-incisional Wong's pockets can be put. That's not a very major thing, but I would prefer to put sutures both in my main port as well as my side ports, because I don't want even that micron of ingress into the anterior chamber, especially when you have a vitreous loss and you have this thing, because I don't want any endophthalmitis. Endophthalmitis is a very more serious problem in a vitreous loss, especially when you have not managed it properly. So that is the reason why I want to make sure, doubly sure, because better to be safe than sorry. And that is the take-home message I want to give. Personally, I put sutures whenever I have a PC tab.
Like Dr. Gaurav has told good number of times, after closing the incision, he just puts in the dye over it to see whether there is a leakage or not. Once it is not leaking, your IOP is very much normal. Probably there is no chances of ingress in these cases.
100%, sir. It has been proved also. There are several papers, I understand fully. But what I'm trying to say is, please understand, over a period of time, during the post-operative period, every time the patient blinks, okay, there can be ingress. There can be ingress, especially when you have a clear corneal wound. And if you have sutures, it will not happen. It will not happen 200%. That is the reason why I'm saying.
It is secure for longer time.
Yes, sir.
Absolutely,
sir. Long term.
Dr. Dhami, can I have a...
They cannot have topical anesthesia.
Yeah. It is in the immediate post-operative period that there is some, as Dr. Mohan has said, rightly said, that there is some ingression of whatever is there in the cul-de-sac. And with an open capsule, Supra Wong's incision pocket really makes a lot of sense. But then incisions, I would go by giving incision, not incision, the sutures in all patients wherein such situations arise.
Yes, sir.
Can I have a...
Can I add something?
Yes, Shivan.
Can I add something?
Please.
Sure.
I think I also tend to agree with Dr. Mohan. You see, the suture does two things. Number one, you just had a rent. Your heart is beating a little faster. So once you put a suture in place, it tends to allay your anxiety and you're far more in better control. Number two, that when there's a PC rent, your maneuvers are more in the wound than your normal 3 minutes or 3.5 minute surgery. So your wound stretch would probably tend to disfigure the wound slightly. Number three, if you're putting a 3-piece IOL, the wound size is slightly larger than your normal 2.2, 2.4. So you need to enlarge the wound. And number four, what Dr. Mohan Rajan said, if there's been a vitreous loss, there will be some hypotony. Though I agree with Dr. Thin that if you seal the wound, but I feel one small suture doesn't make a difference. It gives you the sense of satisfaction, and especially for a beginner surgeon, I guess, maybe putting a suture in the center in a 2.8 or a 3 millimeter wound actually bifurcates the wound into 1.4 or 1.5 millimeter and tends to give a surgeon a better relaxed night, and the patient also is better.
Putting a suture is not a crime.
Yeah.
The take-home message is putting a suture is not a crime.
I agree with you, Dr.
That's the carry-home message. I think we can push on. That basically, once you are in trouble, even a minute of incision enlarged is not going to be uniform. Your blade is not going to do the same job as it was going with the full at the beginning. So mainly irregularity in the incision can be corrected, and as Dr. Arup said correctly, putting a suture is not a crime, nor a default.
Absolutely.
Thank you everyone. Thank you, Mohan.
Thank you very much, sir.
And
thanks
now
for the wonderful opportunity, Dhami.
Thank you. Now, since we have all our panelists with us,
Dr.
welcome.
Dhami, I wanted to have I wanted to share one fact.
Yeah, please.
And Dr. Mohan Rajan, congratulations, sir, for a wonderful talk.
Thank you, Deepak.
And I am also a retina surgeon and a cataract surgeon as well. So even when I do combined surgeries, when I'm doing a phaco and a vitrectomy, we have been taught that you should always suture the incisions, as these incisions, as after a vitrectomy in any eye, on the table it can be taut.
Yes.
The eye can be absolutely taut, the incisions can be sealed. But once you patch it and you open it in the morning next day or after a few hours, it becomes hypotenuse. So that hypotony can open even the tightest of incisions which you have, because it is basically deformation of the globe. So we have to be very careful in suturing any eye which is vitrectomized, even if it is an anterior vitrectomy with a vitreous loss.
Yes.
And I had a incident in which one of my capsular hooks got stuck into the CTR and subsequently into the IOL. And I had to actually go inside, use a micro scissors, cut the hook and leave it there, that edge, and the case went off fine in the end. So we have to prepare for that eventuality as well, as I was just not able to remove that fragment.
Thank you.
Thank you so much.
That's very well said. And I take here a minute to introduce my great friends, the panelists. Dr. Brad, excellent, innovative, and a perfect surgeon I would like to go to. Dr. Singh, proud of you to be here on Sunday. Dr. Singh is the director of the Sindh Eye Hospital, Jalandhar. Dr. Randhawa from Patiala, one of the premier persons in refractive surgery. And I should have started, I missed our Honorable Vice President, Dr. Pushpinder Kaur Bora. Thank you, ma'am, to be with us. Above all, our past president, Dr. Dinesh Garg, past president of POS, and our General Secretary, Dr. Ashwini Kalia, and not forgetting my friend from Ludhiana, our president, Dr. Sukhjeevan Kakkad, and our General Secretary, Dr. B.S. Rana. Thank you to be proud of you, and I will request Abhinav to moderate further before I introduce Dr. Arup. Well, if at all you have to think what you missed at a big meeting of 5 days at All India conferences, you'll have to remember Arup. He puts them online so meticulously that you can attend, learn from every session which has gone into AS. I honor you, sir, for that great effort you have given us. We are always live on AOS conferences now. That's just because of you. Dr. Arup is our editor of proceedings, AOS. He is a prestigious member of IIC. Achievement is innumerable. Books, journals, case presentations, international, nationally, conducting courses internationally. If you happen to attend one of his courses internationally, it is overcrowded. You'll have to stand over the chair. He has more than 50 books and more than 1,500 chapters in presentations. And I have already described you his instruction courses at ASCRS and ESCRS. I welcome you, sir, Dr. Arup, to this webinar to put forward your views and give us the best of the ideas. Dr. Abhinav, can you go ahead?
I think we are welcome Dr. Arup, sir. We'll be speaking on salvaging the sinking lens. Sir, the stage is yours.
So good morning, everybody, and thank you, Dr. Dhami, for having me here for this meeting. As I always feel, I mean, my best case scenario or my worst case scenario is yet to happen. So the best is yet to come, the worst is yet to come. So I'm going to present to you a series of cases where the intraocular lens was sinking and how we managed to salvage it and come out with flying colors at the end of the surgery. So here is my first case. So this is the microscope view, and it is very clear that the intraocular lens is decentered. This is the right eye. It is decentered on the nasal side, and it is cutting the pupil, which is well dilated. This is the preoperative view, where again, the lens edge cuts the pupillary space, as well as, and when it is dilated, you can see the significant east-west decentration that has happened. And obviously, we don't expect these patients to have a good vision. So his best corrected vision is only 624. And that is only in terms of the quantity of vision. As regards the quality, when I put the patient on the eye trace surgical workstation, you can see so much of high order aberration emanating from the entire eye. And it could basically be traced to the intraocular lens. The cornea was relatively clear. So here we have a patient who has a decentered intraocular lens. His vision quality as well as the quantity of the vision is affected, and he requires a surgical intervention. So if you analyze this case properly here, the lens is decentered towards the nasal side. It is a 3-piece hydrophobic acrylic lens. The lens is inside the bag, in the capsular bag. So there is a peripheral posterior capsular rent or a zonular dialysis on the nasal side, through which the haptic has slipped in, and it is lying in the peripheral retina on the nasal side, and the intraocular lens is decentered. So here, my game plan is going to be, to bring the entire lens, rotate the lens back into the bag, and then obtain a reverse optic capture, because the bag is more or less stable. The capsular bag is more or less stable, though there is a huge defect in this side. This bag has been stable for more than a couple of months. So I decided to use the residual capsular bag to support the intraocular lens by rotating the lens, keeping the haptics in the bag in a safe area, and then pushing the optic forwards, reverse optic capture, and stabilize the lens in that manner. So let us see how the case goes by. So it has to be a closed chamber maneuver. We don't want to be losing the anterior chamber depth. There is no vitreous in the anterior chamber. The anterior vitreous face is intact. So it has to be kept that way. We also cannot afford to traumatize further the capsular bag as well as the. Am I audible? Okay. So I decided to use a lot of OVD, dispersive OVD to form the bag, to open up the bag to support the posterior capsule, the area of the zonular defect, and make sure that when you make the incisions are through the virgin areas, not through the scarred areas. And I'm going to make 3 paracentesis tracts, as you see here, to give me a direct access to the different parts of the lens, so that when you rotate the lens or when I manipulate the lens, bring it up, it becomes easier. So again, a dispersive OVD is injected under the rhexis margin, under the fibrosed rhexis margin. We have to be very, very careful. We have decided to stabilize the intraocular lens on the capsular bag. So we cannot afford to traumatize the capsular bag. The rhexis has to be intact. The PC lens, which was already there, should not be opening up more, should not be enlarging. So the lens, using a bimanual technique, very carefully, using the Sinskey hook, the lens is rotated back in the bag, and it is brought, the convexity of the haptic is brought 90 degrees away from the area of the posterior capsular rent or the zonular dialysis, whatever the case was. So at this situation, we see that the lens is pretty stable. Now, do we keep the lens like this? If we keep the lens like that, there's always a chance post-operatively, if the patient rubs the eye, patient moves the eye, the lens may rotate, and we may again have a situation where the lens goes back to the original position. So here I'm trying to achieve the optic capture, always a bimanual technique. The rhexis overlap on the nasal side was quite significant. So you try to get that portion of the lens at a more anterior plane, and that is achieved. You have to achieve that using a bimanual technique, and make sure that the edge is brought anteriorly and pushed in front of the anterior capsule. So I have partially brought the lens in front of the capsular bag, and the trailing, the rest of the temporal portion of the edge of the lens is easier because the optic, the rhexis overlap is not very significant in that area. So now we have a situation where the intraocular lens is lying in the capsular bag as it was earlier, and the optic has been brought anteriorly, and I have used the capsular bag to support the residual capsular bag to support the lens. So this has allowed me to come away with minimal manipulations within the anterior chamber. The tap test is being performed just to ensure that the lens really doesn't destabilize, it doesn't get decentered, and it is all fine. And I also did use triamcinolone acetonide, preservative-free 1:10 dilution. And so there's no vitreous here. So though it is not shown here, but you have to believe my words. So this is the before and after picture on the operating table. So such a well-centered intraocular lens. This is the before and after picture on the slit lamp. This is what you had to start with. And this is at the end of the surgery. Patient regained an uncorrected vision of 6/9. And when we again reviewed the patient on the workstation, you saw that all the higher order aberration which was there preoperatively, everything is gone. There is some amount of corneal astigmatism, induced astigmatism that has happened. And that generally, I think, will be taken care of in due course of time. So here we have managed a patient which was about to sink into the posterior segment. Same lens has been refixated within the capsular bag, taking help from the capsular bag, and the patient has done extremely well. So this was the first case. I wanted to show you another case, little different, but surgical principle is more or less the same. Now, sometimes when the cataract surgery goes on well, we tend to relax, and for the intraocular lens implantation, we are a little relaxed, and this is what happens. If there's a particular case which had gone off well, and when he implanted the intraocular lens, it was sort of sinking into the vitreous. So something had to be done. So let us see what exactly this case was. It was an uveitic cataract. Cataract surgery was uneventful. this patient, we used a 3-piece hydrophobic acrylic lens. The lens is delivered within the capsular bag. The leading haptic, I thought everything was going on pretty well, but as you see here, after the leading haptic is entered and is implanted in the bag, and as I try to push in the trailing haptic, there is the lens which is totally decentered. Okay.
Yes.
Yeah. So, which is totally decentered. So now the first thing first, you have to make sure that there is no further trauma to the anterior vitreous face. Fortunately for me, the anterior vitreous face was intact. You also got to ensure that the trailing haptic, the lens doesn't go into the vitreous. So the trailing haptic was exteriorized. And then here I wanted to use the capsular rhexis margin to obtain the optic capture. We use the capsular bag, residual capsular bag, and have the haptics in the sulcus, but push the optic through the rhexis into the capsular bag, which is just the opposite of the previous case that was shown to you. So the intraocular lens is quite stable now. It is not going to go down. I'm using generous and copious amounts of a dispersive OVD, which forms the anterior chamber, which protects the anterior vitreous face. And this is the way of tucking the haptics, just sliding it under the iris in front of the anterior capsule. This is to make sure that the haptics do not go into the capsular bag. So now we have a situation where both the haptics are lying in the ciliary sulcus, very carefully, we are very sure about it. And then the haptic is pushed behind. Now, sequentially at multiple points, I tap the optic. It goes inside the capsular bag. So we have a very, very stable arrangement. The haptics go in the sulcus, and we know sulcus is not a very good place for the lens to stay, both short term as well as long term. But when you capture the lens optic, when you lock in the lens, it is a very stable arrangement. So I try to remove as much of the OVD as possible. And in this case, I again used triamcinolone acetonide 1:10 dilution. You don't really have to use the full undiluted 4% solution, preservative-free solution. So you see, there is absolutely no vitreous at the end of the case. So here we had a situation where it was an iatrogenic defect, a huge PC dent, and let me show you the previous video. So now, why did the PC dent happen? So there was a slow motion here. So now you just observe very carefully. This is a slow-mo. So the leading haptic, it comes out and it comes out vertically. It impinges against the posterior capsule. It makes a hole. It sort of punches through the posterior capsule, which I don't realize at that moment. And then when I rotate the lens, in order to keep the lens in the capsule, the haptic in the capsular bag, the PC dent becomes much larger. And so that is the reason why PC dent happened and why it enlarged and why the lens was tending to go down. So what would be the take-home message? Whenever you are using a 3-piece hydrophobic acrylic lens, so yeah, anyway, this was the second case. This is the post-operative view. The lens is very well centered, and you can see that this is the nasal side, and this is the area where the nasal posterior capsule is totally absent. And this is ovalization of the rhexis margin, which is very clearly seen. So the lens is very well settled. So what are the lessons that we have learned from these two cases? Whenever you use a 3-piece hydrophobic acrylic lens, you make sure that the capsular bag is inflated. The posterior capsule there should be sufficient amount of OVD in the capsular bag so that the posterior capsule is concave. It is not bulging forwards, because if it bulges forwards, and as the leading haptic tip comes into the bag, it is surely going to hit the posterior capsule, and you're going to end up with a PC dent that you saw happen here. So there should not be any panic reaction, no knee-jerk reaction. So I could have really lost my nerve, and I would have enlarged the incision, brought the lens out, and gone for other intraocular lens options. But then I realized that this was a situation which was definitely salvageable if I could just take out the trailing haptic and keep it outside the section so the lens doesn't go down, and protect the posterior capsular rent area, the anterior vitreous face with a dispersive OVD. Viscoat, it has to be used. So a PC dent is not tantamount to ruptured anterior vitreous face. You can have a posterior capsular rent, but your surgical manipulations should be very, very gentle, should be very, very gingerly, so that you don't enlarge the existing PC rent or don't break the anterior vitreous face. And whenever you suspect vitreous, it is always a good idea to stain the vitreous with triamcinolone acetonide and manage appropriately. We have seen a couple of good videos from Mohan Rajan how to do an anterior vitrectomy both from the limbus as well as from the pars plana. And so another thing for them, if there are youngsters watching it, if I was lucky because I was not dealing with the single piece hydrophobic acrylic lens, these are the lenses which should never go in the ciliary sulcus. If I am also not very comfortable obtaining a reverse capture of the optic of these lenses. For example, if you have a situation where the haptics are in the sulcus, in the bag of these robust the single piece hydrophobic acrylic lens, and obtain a reverse optic capture, the square edge is pretty sharp, and it can always result in UGH-like syndrome. So this kind of lenses should never have any relationship with the ciliary sulcus. In Indian scenario, the best lens that we have available is the sensor lens, which has a 13 millimeter overall length and a optic size of 6. I would prefer to have a lens which is 6.5 millimeters in optic diameter and overall length of 13.5, but that's not available in our country. And sometimes when we have to place a lens in the sulcus, and we know the power of the lens in the bag, this is the algorithm that could be used. So the rule of thumb is, you reduce 5% of the bag power to arrive at the power that is going to go into the sulcus. So that is the rule of the thumb, and this is actually taken from Warden Hill website. So it is put up in my OT table. So in case I have a situation where I need to know what is the corresponding sulcus power, so this is what I do. This is my final case. Now, if you see here, the end of the surgery, everything is going on well. I'm using a cohesive OVD to fill up the bag, form the anterior chamber, and the leading haptic, the lens. No, I really have to struggle to push in the cartridge. But then, I realized that maybe the AC would have become shallow, but I injected OVD again through the side port incision. The leading haptic goes in perfectly fine, and everything is as per plan. Everything is under control. And when I come for the trailing haptic, you please do not blink. You'll realize something that happens. So this is kind of a snap that I feel. At this juncture, there was a snap. So I could definitely feel that something has given way when I was trying to dial in the trailing haptic. My rexis was slightly small size. This is the slow motion view. At this point, there was a snap. So what had happened is in the step where I try to dial in the trailing haptic, the posterior capsule gets stretched, and this happens in all routine cases. But in this particular case, God only knows why the posterior capsule then it gave way, and there was a large PC dent. So now what do I do here? Unlike the previous case, where the lens was going to go south, here we have a lens which is very, very well centered. But I know there is a huge posterior capsular rent. It will be shown little later when I take a higher zoom view of this thing. So I decided to leave it alone, because if the lens is well centered and though there's a PC rent, so somehow the available capsular bag is sufficient to keep the lens in the sulcus. So if in the bag, so if you see here, this is the nasal side. This is the PC rent. From this area to here, the PC exists only from this line to the temporal side, and this side there is no PC. In spite of that, the lens is quite stable, and I decided to leave it alone and see the patient on the first post-operative day. This was the first post-op day picture. The lens was very well centered. This is again, you see the best corrected vision was 6/6 partial, and this was the large PC dent. This is the temporal side, and this is the nasal side, and there is a differential vitreous pressure on the optic. The portion which is supported by the posterior capsule and the portion which lacks in the posterior capsule because of the PC dent, there's a differential pressure gradient, and there may be some amount of lens tilt, which is not clinically significant because the patient is pretty happy with the vision, but there is some amount of aberration. So that can happen, when you have a large PC dent and you have a lens resting in the ciliary sulcus. So friends, before I conclude, I would say that many cases of decentered and dislocated PC lenses can be reposited simply by employing a residual capsular bag support using proper surgical techniques with good anatomical and functional outcomes. There have been cases where we have managed posteriorly dislocated intraocular lenses lying in the vitreous. We have used the capsular support to you so much for your kind attention.
Thank you, Roop. It was a wonderful talk, and probably some tips to carry home, that don't lose your nerves once you are in and halfway through a very good surgery. Finally, virtually when you're inserting an IOL. Dr. Brad, I'll request you to come over and as a panelist give us some comments. Please unmute yourself.
Good afternoon, gentlemen. First of all, thank you very much, Dr. Dhami and his team and LOS for giving me opportunity to be here with you. We have had a wonderful talk by Dr. Arup and Dr. Mohan Rajan. Well, the tips given by Dr. Arup are really wonderful and worth emulation by all. Only thing is preparative planning makes the things much easier. And well, whatever Dr. Roop said are beyond controversy. Everybody should emulate whatever he said. Thank you very much for the wonderful talk. I think he doesn't need any tips. Everything is to be done.
Thank you, sir.
Yeah.
Welcome, Dr. Karamjeet.
Just one thing I wanted to say about rather Dr. Rajan's talk. Somebody had commented, somebody had asked him a question, what to do when the nucleus is down there at the retina, how to take it up. I would say that let the retina surgeons do their job. And Dr. Rajan is a retina surgeon, he can do the jobs both ways. And if we try to fish out something from the vitrea, something from the retina, lying on the retina bed, we might tear it up. And better leave the things alone, don't fish them out, and let the retina surgeons handle the job in a better way.
Absolutely. Fully agree with you. Can I add one thing, Dhami?
Yeah, please.
No, I really liked Arup's talk because all the cases, what he showed is a multi-piece lens, 3-piece lens, and he was able to capture the lens, either a optic capture, reverse optic capture, he was able to do that. Personally, what I do whenever I put a multi-piece lens, what I do is, I don't dial it inside. If I dial it inside, in my hands, what happens is, there is producing a lot of stress on the zonules in the posterior capsule if we try to dial this lens inside. So what I do, I take a McPherson and then try to tuck it inside. And when I tuck it inside, I'm very sure that it is going to be, suppose I have a PC tear, I want to be on the sulcus. I want to make sure that it is on the sulcus, exactly where I want. Or if I want to do it in the bag, I just rotate it, tuck it inside with the McPherson. So what's your take on that, Arup? And
Mohan, a McPherson is a big device. It opens up the incision. You have to go through the main incision. So you should use a Kuglen hook or a Sinskey hook, some push-pull kind of instrument, or a micro forceps, which goes in through the paracentesis incisions. So if you see clearly, I mean, so I needed to specify a few points here. That when you try to engage the haptic, the trailing haptic, when you try to before you push it under the iris,
yes,
don't try to engage it at the periphery where there is no view. See, the lens is lying in the anterior chamber. The haptics are in the iris. There may be a lot of arcus senilis. So hold the haptic near the haptic optic junction with the Sinskey hook, and then slide the instrument, slide the Sinskey hook or the Kuglen hook along the convexity of the haptic, and you push it in. Yeah. Because in my earlier days, I have realized that I have traumatized the anterior chamber angle. There has been some bleeding when I tried to grasp it at the maximum convexity right at the beginning. So instead of that, you engage the haptic at a more proximal area as far as the optic haptic junction is concerned, slide it around, and then you flex it, and then you just tuck it. You don't really have to bend it too much. You just flex it so that you come within the pupillary area if you're going to push it in the sulcus, or within the rexis margin if you're going to push it in the capsular bag, depending upon the stability and the status of the posterior capsule.
Just one thing regarding the dialing of the trailing haptic. Once the rest of the IOL and the leading haptic are in the bag, well, if we are doing with McPherson forceps, the pressure on the bag will be put if we don't take the help of the left hand. Some rod in the left hand has to little depress the optic so that the McPherson tip lands it right into the bag.
Yeah.
So
I think there's another click in it. What Dr. Mohan was, I suppose, trying to say. The position, the bag has to be properly inflated. There's no absolute way. You have to see case based. My first preference is the way Dr. Mohan does. What I do is I hold the tip of the loop from the tip of the McPherson forceps with the bag properly inflated and just dial it in. So the tip is to hold it at the tip itself.
Yes.
And if it doesn't work, then what Dr. Arup said can be followed into. But what I do is instead, because I too had a case of posterior capsule rupture. So what I do is I just inflate the bag more, put from the side port, put the pressure on the optic itself and just push it in. So that will push the, that's no doubt slightly more traumatic, but with the bag properly inflated, you can easily push it in on the optic from the optic itself.
Dr. Rohit, I'd like to add something. Just want to ask one thing. When you're holding the haptic from the tip and with McPherson and putting it inside, what are you exactly doing with your left hand at that time?
Basically, I'm not doing anything because with the bag inflated.
Bag is inflated.
Yeah, bag has to be proper.
But I feel the left-hand guide is still better.
Yeah, absolutely. You
can do that.
I'd just like to add one thing, though I agree with everybody. What I do is, number one, I inflate the bag. Then I use a Y-shaped blunt instrument and I embed it at the junction of the haptic getting inside the optic in that junction. So what it gives me is, it gives me a control how my haptic is going to go inside the bag. And with one hand, my left hand, I hold the trailing loop tip with my McPherson's. And I dip the Y rotator downwards into the bag. And as the loop is going in, my left hand just guides it in. And the moment my trailing tip enters the wound, I leave it. And then it's automatically dialed into the bag. Works for me 100% of the time. So if you want, I can show you some videos.
We are missing the main point. See, we are talking about inflating the bag. The bag and the posterior capsule is at its highest risk with the leading haptic. So you have to have the bag absolutely inflated when the leading haptic goes in, because that is the stage. Yeah.
Absolutely. If I make a point, we are till now dealing with two incisions, the main port and the side port. Dr. Brad rightly mentioned of third hand, and we can create a third incision if you're not doing a bimanual and not manipulate through the main port, use a closed chamber and a smaller instrument to manipulate the IOL. I think we'll be doing better. But it was excellent, Arup. And if panelists have no question,
we have a couple of questions from the attendees of the webinar. So, Dr. Arup, sir, what is the effect of the optic capture, reverse optic capture on the post-op astigmatism? And second, have you tried the Orolab lens, which is similar to sensor? And third is, what are the complications that we can face when you put a foldable IOL in sulcus?
Yeah, so there are three questions. One is about whether I have used the Orolab lens. See, I have trialed no financial interest. I have trialed most of the 3-piece hydrophobic acrylic lenses, but then I have gravitated towards the lens, the sensor lens, because I have had a more than 20 years track record with this, and this has never let me down, unlike the other lenses. There's another lens that was being sold from Epsilon, I think. For some time, I tried it out, but again, we had issues. So so my experience is basically a good experience is limited to the sensor lens, and other lenses also may be good, but I really cannot, I'm not in a position to comment much about those lenses. The second point is, now when you are obtaining a reverse optic capture, the question more important than the astigmatism, what will come up in my mind is the intraocular lens power issues, because we have calculated the lens power to be when the lens is in the back at a more posterior plane. Now we are pushing this optic a little more forwards, bringing it anteriorly. Now it is lying in the sulcus. All right, so there may be certain issues in terms of the changing postoperative refraction, target refraction, what was meant for. But I think that is a very small price to pay. We just may have to alter the intraocular lens power, by the spectacle power by 0.5 or something like that. So astigmatism wise, I don't think that has really been an issue, because it's a very good question. It's a very valid question, because now we have a lens which is angulated posteriorly. Now we are making it angulated anteriorly when I do the reverse haptic capture. So whether any lens tilt happens or not, clinically it has not happened. And in the first case that I showed, there's some amount of astigmatism because I'd taken multiple incisions. So maybe that was the responsible for the about 0.75 diopter of induced astigmatism that happened in that patient. And what are the third question? The third question.
So what is the complication if we put a foldable IOL in the sulcus?
Yeah, see the foldable. See the one that I've used is also a foldable lens. My question is, so what I tried to address was a single piece lens, single piece hydrophobic acrylic lens, or a single piece hydrophilic acrylic lens. All right. So the single piece, this is one piece or a 3-piece lens. So the problem of using a single piece hydrophobic or hydrophilic acrylic lens in the sulcus is, these are very bulky lenses. So they keep on rubbing against the posterior iris surface, the iris pigment epithelium. There is continuous pigment dispersion. Later on, they can give rise to a pigmentary glaucoma. UGH-like syndrome can happen. There have been cases of corneal decompensation that I have seen. In fact, I have managed many cases where there have been referred patients where there's asymmetric implantation, haptic in the sulcus and one haptic in the capsular bag. So I had to put the whole thing in the bag. So those patient symptoms were smoldering inflammation. They were on steroids and NSAIDs for a long period of time. So I think these are the reasons why a single piece hydrophobic acrylic as well as hydrophilic acrylic as such should not be implanted in the capsular bag. In the ciliary sulcus.
There's one more question: that does it convert into a posterior capsular rhexis? Would the change of IOL be in consideration?
What is the question?
If you make a posterior capsular rhexis, would you still consider changing the IOL towards a 3-piece, or would you still put a single piece?
We can put a single piece.
Okay.
With the posterior capsular rhexis, is a small rhexis, we can go ahead and put a single piece in the back.
See, in terms of this, in terms of the single piece lenses, the optic capture, we would not like to capture the single piece lenses anteriorly, because of the reasons that I mentioned. But if you can achieve a posterior capture making a rhexis, that is perfectly all right. In terms of the complications which I've just mentioned.
Yes, Kamal.
Sir, I do agree with you, Dr. Arup, but I'd just like to share my experience. I've had situations where the patient wasn't for a multifocal, very low power, 2 diopters, 2.5, 3 diopters, had a PC rent. Now I planned a secondary IOL. I had a choice of going in for monofocal, patient very, very hard pressed for multifocal. So what I did was I got custom made 13.5 millimeter optic single piece hydrophilic lenses in Rayner design at 6.5 millimeter optic size. And I've done 4 of such cases, and it's been nearly 4.5, 5 years. Patients are doing fine. But the edges were not rough edge or square edge. They were all rounded edges. And the powers were lower powers.
Dr. Kamal, we're talking about a different lens, Sulcoflex lens.
I'm not talking about Sulcoflex. This is a custom-made lens. I don't want to name the company. Well, if you want, a care group made these lenses for me at 13.5 Rayner design with 6.5 millimeter optic, multifocal with non-square edge. It was a rounded edge, and the patient is doing fantastic.
I think
now here we are doing a worst case scenario where we are in the OT and we can't have a different lens now.
Yeah.
No, sir, but this was the patient I just shared for the knowledge that
no problem.
We called the patient after 2 weeks, got a custom-made lens and put the lens.
I have one more question of you. Kamal, Rajan and Dr. Sen, we have been talking till now everything about non-femtocataract surgeries. Let's see if these things do happen, Kamal, when you are doing a femtocataract too.
Yes.
Can you give us some tips?
Yes. In fact, I'll be showing you a video, one of the videos.
I saw one of the videos there, Kamal.
See, femto is like your normal cataract surgery. There is a slight learning curve of femto. Maybe for my first 100 cases, I did have issues. Well, now we are down 5,000, 6,000 cases down. But first 100 cases, there was a huge learning curve. The whole anatomy of the eye changes, the handling of the cataract changes, the way you do your irrigation aspiration changes, your hydrodissection changes. So that is a learning curve. But once you bypass that, the complications can be the same. Yes, sometimes if you have a corneal opacity or subtle corneal opacity, you will have an incomplete rhexis. You will have a peripheral extension of rhexis because you would think that the rhexis is complete. You will pull on the tag. So these kind of things do happen same. But the saving grace is in a femtorhexis, your rhexis is very precise and central, 5.25. So in case, God forbid, you have a situation, your CTR can go well, your sulcus fixated lenses can do well. But otherwise, I guess femto can give the same amount of complications what at least I feel what a manual surgery can.
Thank you. That's a big consolation for average.
Dhami, can I add one thing?
Sure.
No, femto, because femto, you have to be careful. Please understand there is a learning curve in femto as well. There can be complications, especially when you have a mature cataract. Please understand that it's not a free-floating rhexis. Even in a machine like Catalyst, there can be skip areas. Okay, if you try to pull the rhexis, there can be a PC tear. There can be a rhexis tear which can go during the surgery across the equator into the posterior.
Absolutely. I'll show you some videos if you want.
So make sure that you stain. What I do is I stain, and just like a regular rhexis, look for the skip areas and make sure that you complete the rhexis, and then you will not have any problem. I have had problems initially. I've had problems in a brown cataract wherein the rhexis has torn and gone back, and I've had nucleus drop even with femto. So there is a learning curve in any technology for that matter.
Dr. Sindhu there, I think, to you. Dr. Singh, can you unmute yourself?
I'd like to just add what Dr. Mohan said. Classically, in white cataracts, there'll be some calcific areas where the laser will not cut. So it's a huge tip for the beginners, what Dr. Mohan said, stain all your white cataracts after you've done your femto, because you will miss the skip areas. And if you pull on the skip areas, I've got at least 7 videos with me. And if you pull on the rhexis without ensuring a skip area, you will have a peripheral extension. Without knowing, you'll have an Argentinian flag sign.
Absolutely.
So it's a myth when people say that a femto will be a sure shot proof for a white cataract. You need to stain your cataract and you need to know the rhexis and then go ahead. Secondly, if you have a very steep cornea, you may have skip areas because the cornea will fold when you dock. And third is if you have slight opacities or arcus or vascularization on the cornea, you will have skip areas in the rhexis. So we need to watch out for these things.
Dr. Dinesh, you had something to comment?
First of all, I must congratulate Dr. Aru. I just had one concern, sir, like the high molecular weight OVDs, especially with the PCR. In the first case which you showed, they go down into the vitreous, and sometimes you get a very recalcitrant kind of a secondary glaucoma. So is it like that we should do it under like putting a pars plana cannula or a
Sir, I think it is a very, very, very valid question. Thank you that you asked that question. See, in the first case or the second case, there was no PC rent. There is no vitreous disturbance, so vitrectomy wasn't done. So there is no question of the OVD going behind and mixing up with the.
No, the one which was a lens which was subluxated, IUL which was subluxated and repositioned.
Yeah, so but there's no vitrectomy done. There's no vitreous disturbance, both these cases. But you know, if we really have to use a OVD from the perspective of reducing the incidence of postoperative ocular hypertension, I think Viscoat is the best. Any chondroitin sulfate-based OVD is better than 2% HPMC. So I would definitely not recommend 2% HPMC. I would definitely say that Viscoat definitely is the OVD to use in these kind of situations where you feel that vitreous and cortex and OVD have got mixed up. And you may have some amount of residual OVD because you don't want to, do further vitrectomy and cause further vitreous loss and further vitrectomy. So some residual OVD stays put inside the eye. We manage the ocular hypertension for a few days postoperatively. But if it is HPMC, then you really had it. The pressure is recalcitrant.
That's a very good point, Arup.
I fully agree with Arup because HPMC and the vitreous is like ADMK and DMK in Tamil Nadu. Okay? Yeah. It is like absolutely. HPMC mixes vitreous, produce severe vitritis also, and also secondary glaucoma, all these problems can occur. But viscoat, probably you can lead in some viscoat, nothing happens, and these patients do very well.
That's a good point. Dr. Brad, you want to say something?
I just wanted to add one point regarding IOL capture. And once we have committed the patient multifocal lens and we are operating, and sometime in our aggressive PC polishing, we get a tear. Now we are really caught what to do. Then we have committed the patient multifocal lens, he has paid the money, lens is already opened, lens is loaded, and where do we go? That is the question which is very important, and I think this today's webinar is all about once we are caught. I feel if our rexes is 4.9 to 5 to 5.2 with PC tear and nicely managed PC tear, we can do PC capture at 90 degrees to the haptic, and patient does very well. I've done a couple of cases in which I vigorously polished and inadvertently there was a PC tear. I had nothing else to do. We captured the PC, only provided one is very careful about the size of the rexis. If the rexis is not 5.5 or 6, it's about 5, we can capture, and then the PC has to be captured at 90 degrees to the angle of haptics. That's it. It can be captured.
So if you have captured it, the relationship 90 degrees or 60 degrees, that doesn't matter. Yeah. Because it is the rexis which is stabilizing the optic. Right. Yeah. So it's not going to rotate. It's not going to get displaced.
I'm just telling when we're dialing, that's how we should, and it stays there forever.
Please, can I add a point?
And one thing more regarding astigmatism. Sure. Astigmatism is born out of the position of the IOL. If it is well centered, is well captured, equal on all sides, there will be no astigmatic change. Patient will be happy.
Yes, there's a tilt.
Yes, Ashwini, you wanted to say something?
Sir, how to decide on the particular case whether the reverse optic capture is a better option or forward capture?
Yeah.
How to decide in a particular case whether the reverse optic capture is a better option or forward optic capture? You can hear me?
Yeah.
Dr. Roop?
Yeah. So the question is, how to decide whether to make a reverse optic capture or a forward optic capture. Now, yes. now when we have a large posterior capsular rent, in that case, there is no way we can keep a lens in the sulcus, in the capsular bag. Right. So we have to keep the lens, 3-piece lens in the sulcus, and then we have to do a posterior optic capture because you have sulcus is the only place where you can keep the lens. On the other hand, a situation which Dr. Brad was talking about, that you have a piece posterior capsular rent, and let's say a multifocal lens or even a single piece lens, even a monofocal lens, and you're not sure whether it's going to stay or not, then you obtain a reverse optic capture. You bring the optic in front of the rexis margin because the haptics are resting in the capsular bag. But again, there are certain conditions that I want us to be careful about, which we have already discussed about the problems, because these optics are basically very thick, square edge, sharp edges. So these have to be, taken into account, and these are complex situations. So there will be, complications. Chances are much more, and then we have to counsel the patients. But this is roughly the scenario. When the haptic lens is already in the bag, in that case we obtain a reverse optic capture if everything is okay, and then if the lens keeping in the sulcus, then you put it in the buttonhole and put it in the capsular bag.
Good.
Can I please add a comment, Dr. Dhami?
Oh, sure, please.
Yeah, I'm Dr. Chekitan. Thank you so much for the opportunity, and Dr. Arup's presentation was excellent. So for the learners, as we have been using 3-piece lenses for a long time, as they said, the bag should be full. So when we are enlarging the incisions, we fill up the bag. But just before putting in the lens, I usually again fill up the bag just before putting in the lens. That helps in making it really concave. And if we see the sensor videos from the company, in a single go, you can put in the lens right into the bag without any Sinskey hook or without any instrument. You do not actually need anything. Third, if there is a large PCR and if we are planning to put a lens in the sulcus, you can use an infusion from your left hand that can stabilize the eye, and you do not need a viscoelastic. You can just introduce the lens under fluid, and there is no viscoelastic, introduce it into the sulcus and capture it. So that will absolutely eliminate chances of any viscoelastic entering the posterior segment or even the anterior segment. That really has helped in my scenarios. Even in pediatric cataracts, I've been doing this, infusion related implantation of the IOL.
So that was a good point. About 15 years back, I did some videos about how to implant a sensor lens. But the thing is, for you to be able to release the trailing haptic using the injector, you need a relatively new injector system. Now most of the time we have been using, so the alignment between the piston and, it should be absolute the center of the tunnel. So after repeated autoclaving, it does not happen. But if it is a brand new, first 15 or 20, or maybe 50 cases, you can definitely push in the trailing haptic in a textbook manner. I have 3 or 4 videos, teaching videos made 15 years back. But it's a good point, I think
very nice point.
Can we move?
I just want to add one point on the insertion of the trailing haptic. I feel, Dr. Arup, in my experience, that's what I've been doing regularly. Once we withdraw the plunger after putting the leading haptic and the optic in the bag and re-engage the plunger at the optic-haptic junction and push it forward, it puts the trailing haptic right into the bag, and irrespective of the number of usages the injector has gone through, it works on its own. I've been using the same injector system for the last many years, and it's working perfectly. Only thing is to follow the videos as shown by these sensor people. Just withdraw the tip and then re-engage at optical junction and then rotate. It rightly goes into the bag. Only thing is sometimes we don't want to take such risk while putting the lens in a torn bag or a damaged bag. Only in those cases we want to be extra careful.
One thing I would like to ask.
Yes, Sana.
Yeah, the one thing we have been discussing a lot about PCR. In case of zonular dialysis, how do you manage the same case if the zonular dialysis had happened?
I've got a video coming in. That will answer your question.
Okay.
Very nice.
To reverse capture of in case of toric lens. Reverse
Can we go to the next speaker? Hello, am I audible?
Yes, sir.
Yes, sir. Yes, sir.
Well, to introduce the next speaker, I think I need a music. Dr. Kamal Kapoor does not need an introduction. He's a man who smiles at everyone, and nobody can forget his smile. Well, formally introducing him, he is the founder, director of Sharp Size Center, group of eye hospitals. If you want to learn how to run eye centers and be friendly with your associates, it's Dr. Kamal. Thank you, Kamal. With a chain of eye hospitals, more than 10, and 2 outside Delhi, he is having a great time running here and there. That too, you can learn from him how to manage time. His presence is in Africa, in Mongolia, and Tajikistan. His main of interest is anterior segment. That is aside. His main of interest is music. He has done over a great number, 70,000 surgeries, cataract, LASIK, phakic coils. Probably nothing has been left beyond him. And he has lots to give us today. He has a lot in the bag, in his kitty. Let's see what he says. Dr. Kamal, over to you.
Thank you, Dr. Dhami. At the outset, Ludhiana Ophthalmic Society, it's always a pleasure. I am a thoroughbred Punjabi. And can you hear me?
Yes, sir.
Can you hear me?
Yes, we can.
Can you hear me now?
Yes, sir.
Is the slide there visible?
It is there.
Okay. So as I said, it's always a pleasure. Thank you, Dr. Dhami. Thank you, Abhinav, and the whole team of Ludhiana Ophthalmic Society. It's always a pleasure. And I always say I'm a Punjab da Munda. I'm a thoroughbred Punjabi, though I'm staying in Delhi. I love Punjabi food and always pleasure to do anything with Dr. Dhami. I think it's It's a privilege to be speaking after speakers like Dr. Arup, Dr. Mohan Rajan, and all the senior speakers. I will share some interesting concepts, and the topic I gave Dr. Dhami was rabbits in my hat. The reason was, first of all, I'd like to say, whatever you see here is not just me. I have a beautiful team which works with me, and I am just the mouthpiece. It's all these people who are behind me, and they help in projecting me and helping me a day to work, which gives me so much of time to do what I do, so many webinars, lectures, traveling all across the country, all over the world. It's thanks to this lovely team which manages the work and works everything on an auto mode. So my topic is rabbits in my hat. There are disclaimers. I have no commercial interest in anything I will speak on. I have no commercial interest in any of the products I'll be mentioning. Now, what are the rabbits, I would say? What is a rabbit? All surgeons, we have rabbits in our hat. When I say rabbit in a hat, it is something hidden within us, and we have the power to bring it out. And if we bring it out, it transforms us as being who we are in our operation theater. So I would say the rabbits in a surgeon's hat or my hat would be, first of all, is to have a dexterity and a skill factor, very swift, prompt thinking on your feet, being patient and persistent. Patience and persistence are a big ornament for any surgeon. Having a very innovative mind, thinking on your feet, planning, innovating, improving, seeing others. Observation, intuitive observation. When you see somebody else, you could imagine yourself doing it in your own way, and you could improvise it. And then, of course, a very calm mind. If you have all these rabbits in your hat, you're ready to go. So we will discuss one rabbit at a time. So we will discuss about this rabbit called skill and dexterity. Now, this is a case of 4-day-old trauma in an 11-year-old girl came with a traumatic scleral tear, corneal tear, iris tear, capsular rupture. So what we will do is, I'll just cut the audio. Now I will forward the video in between. Now this is a case. You can see the capsule has been torn in between. The iris is torn. The iris is carcerated into the scleral wound. And there is a tear in the iris, and the cataract is bulging into the anterior chamber. Now I will skip the video. It's a 9-minute video, but I'll skip it. So being dexterous, I'm using my left hand. I will keep changing the microscope position. First thing I do is put in viscoelastic and dislodge the impacted iris from the wound, making sure it was not bulging out of the wound because it was a 4-day-old wound. First, I made sure it was not bulging out. It was just caught in the wound. The eye was quiet. I suture the wound. Once I've done that, then I go to stain the capsule. Now I'm staining the capsule to actually realize how much is torn. Now, since this is a 4-day-old wound, there are posterior synechia with the torn edges of the capsule. So I need to identify how much of capsule is torn. Has it gone beyond the equator? So I slowly inject viscort, and then I separate the synechia, making sure that I do not extend the torn capsular axis. Because if I do that, I'll be aggravating the problem for myself. Once that is done, I will push in more viscoelastic, and now I'm using my favorite wire rotator blunt instrument to push back the iris and identify the torn edges. There I can now identify the torn edges. The capsule has been torn right from 7 o'clock till 2 o'clock. Now this is the area which I'm showing where the capsule has been torn. Now, in order to create it to a rhexis, I use my intuitive, the inverted T technique. This inverted T technique I'll be demonstrating. What I do is I create a T-shaped cut, and I use a micro scissors to create a T junction. Once I've done that, I change my hand. I use my left hand now to extend this tear and create a flap. Once this flap is created, I have 2 flaps. I use a micro forceps to complete it to a rhexis. I'm jumping the video. I do the same procedure on the opposite side. Since this is a young child with a traumatic, so everything I pulled out the whole cortex. I do a bimanual removal of the cortex. There's not much to be aspirated. I push in the lens. Now the trick is I push in the lens absolutely initially perpendicular and dial it in a 30-degree angle to the torn rexus because I don't want the haptics to be stretching the tear. Once this is there, now I go to repair the iris. I use the single throw 4-pass technique. First of all, I pull the iris in from impaction. I clear the viscoelastic and now I start suturing my main wound. Now, I'm doing the single pass 4-throw technique to suture the iris. So I'm using a 3-hand technique. One needle is impacted and left there. I use the ILM peeling forceps to hold the iris, then do the railroad technique to suture the iris. I do 3 sutures in the iris because it's a long tear. Once this is done, and we'll be very happy to see the end result. Using the micro 23 gauge forceps, so see how beautifully the pupil has become round. This child had 6/9 vision on first week of surgery, and the surgeon and the patient both were very happy. So you can see the end result. This is what the patient came with, and this is what was on the table. So this is a classical example of pulling the rabbit called skill and dexterity out. Now this is, we all make mistakes. This is one situation where a VIP patient, I would say a very, very strong political party in Delhi, one of their main conveners came for surgery. He wanted a femtocataract surgery. Galti se mistake and quick thinking saved the day. So this is what we see. Now watch it very carefully. A beautiful femto done, cataract removed. Now I am going to do my irrigation aspiration. And as I said, femto irrigation aspiration is tricky because the cortex is cut flush with the capsule. See what I do. Watch very carefully. There. I pull the whole capsular bag more than 180. There. I'll reverse it again. See.
Yes.
There. The whole capsular bag. But the presence of mind of not to panic, stay there. I'll repeat it again. See. Stay there. Pause. Don't slop your fluid. Go for reflux. So I go for reflux, but I end up catching the bag again. But before I catch the bag again, I use my left instrument to push back the bag which was coming in again. Now I keep the fluid on. With the fluid on, I use my left hand to push in viscoelastic in the bag. Please note, I'm pushing it in the bag, not on the bag. Because if I put it on the bag, I'll break the anterior vitreous face, which is still intact. So I've inflated the bag. By inflating the bag with viscoelastic, there, the whole bag goes back. Now I go in with a CTR. Now I use this CTR. Now always do a white to white of the patient before you put in the CTR and go into approximately 1 mm larger size than the CTR size or the white to white you have. So I thread in the CTR very cautiously. Normally I use an injector. But in this case, I wanted to be very, very sure and very, very careful. And since the direction of my injector would have been the same as the subluxation, I went for the manual insertion there. And as you're in the bag, just tilt your inserter to one direction and leave the CTR ring inside. Now, again, push in the viscoelastic in the bag. Make sure that the bag is full. Now I go to remove the cortex using a Simcoe. I'll be fast forwarding the video. Now, if you're pulling in the area of subluxation, do a tangential pull. Do not do a radial pull. Because if you do a radial pull, you'll be pulling the CTR in the bag again. Try and engaging the cortical edge and pull radially. Once this is done, I'll jump the video. I have interesting videos to show. Again. And by the time we finish, now I'm doing a bimanual aspiration for removing the subincisional because you cannot remove the subincisional with a Simcoe. And there, the case is absolutely perfect, quiet. Nobody can say that we had more than 180 degree of zonular tear without any vitreous anterior face breaking because there was quick thinking on the part of the surgeon and no panic. Now making sure that the haptics are pointing in the direction of the maximum subluxation. This will give extra support to the subluxation and the CTR. And once this is done, the IOL is in the bag. We remove the viscoelastic and do the remaining irrigation aspiration of the cortical plate. And the case does beautiful. And I still see this patient. This is a 2-year-old patient. The patient is still doing fantastic. The IOL is still in the bag. Put a slight amount of pilocarp in, and there, the case is doing perfectly fine. Now, innovative mind. This is the third rabbit. Now, what do we do here? This is an innovative technique which we described in 2005. We also have got it published. I call it the inverted T technique. I'll just demonstrate it in a little more detailed way. We did a seminar on this a few days ago, an international seminar. So what we do is, in a white hypermature cataract, most of the times you'll have an Argentinian flag sign or a rhexis which goes out of control. So you stain it to the trypan blue. What I do is I make a small incision, incomplete incision, push in viscoelastic enough to flatten the anterior capsule. Once I've done that, I take a 26 gauge needle bevel downwards bent with half cc fluid. I puncture the capsule and aspirate the fluid and do a linear movement to create a linear cut. Then I push in viscoelastic to express out any fluid which is there in the bag, enlarge the wound, and then with Vanna's forceps, I give a cut in the center to create a T. Now this T has two flaps. I join the flaps on both the sides to create a complete rhexis. Now this gives you a complete control on your size of rhexis, on the shape of rhexis, because you have two flaps. And in case one of the flap is going out, you can maneuver the other flap inside. So now we'll see a video. We will stain it. Make sure that the stain is good because you want a good visibility of the flaps. We do the stain. Now I make an incomplete entry. You can also use a side port to do this step. I made a partial entry 1/3 because when I do a viscoelastic and a maneuver, I don't want the chamber to leak. I'm using a methyl cellulose here. Now I will go in. I've got the opportunity of demonstrating this technique in a lot of live surgeries, even at Dr. Mohan Rajan's and IRSI. I've demonstrated this live surgery. It works perfect in a white cataract. I put in viscoelastic. Now I make sure that the capsule flattens. The anterior capsule should totally flatten and the iris diaphragm there. It moves backwards. Now I use a 26 gauge needle bent downwards with the bevel facing down, half cc fluid to create vacuum. There I will create an 80 to 70 degree bend, bevel facing down. I will go inside the wound. While going inside the wound, make a side to side movement to ensure you don't engage the cornea or the scleral tissue. Now in one puncture and start aspirating immediately. And you will see the fluid getting emptied. There, the whole fluid is sucked out and the anterior capsule starts flattening out. Mind you, while you are pulling out the needle, stop the suction. Otherwise, you'll pull on the capsule. Now you have a linear cut. Enlarge the wound because now you need to work with the Vannas. In case you work with a side port, you could use a 23 gauge Vanna scissor. Go in, create a cut. It creates a T. It creates a beautiful T. Now what you have is two flaps. Hold each flap at a time and complete the rhexis the way you want. You can control the size of the rhexis now, the shape, in case you want an oval rhexis, you want a long rhexis, you want a big rhexis or a small rhexis. Now your rhexis is not going out of control because the whole capsular turgidity has been removed. So the moment I give a puncture, I put in viscoelastic again to depress the capsular bag and express out any residual cortical fluid from the wound before I give the T incision. And there the rhexis is over. Now patience and persistence, that's another rabbit. This is a case with traumatic subluxation, vitreous in the anterior chamber, a calcified capsule. This injury was 3 years old. This patient came to me and there are some issues which happened in the OT. The OT technician was supposed to get my iris hooks and a Sioni from another operation theater. But this gentleman landed and he forgot the stuff. I was operating in one of my smaller centers where we didn't have the stuff. So I start the surgery. I try and stain only this area because I don't want any trypan flu going into the vitreous. This is a very interesting case. Now I go and start my rhexis. Use viscot. I do a rhexis. Now this time the rhexis is not going to be going very circular because When I want to pull the bag back and put the IOL in, I need to have a rhexis size which should allow my IOL in. So see how I control my rhexis. There is vitreous coming from the opposite side, but it has not come into my wound and not in the anterior chamber. It is just bulging from the zonular break. We can't see it now because that area has got some trypan glue there. I will only push viscoelastic slightly. I don't want to push viscoelastic more because it will push into the vitreous and the vitreous will then start coming into the chamber. Now I use the capsule rhexis forceps to have a very, very controlled rhexis. Now this patient block is wearing out. The patient is moving. Very controlled maneuver. So this is the example of patience and persistence. We go ahead, do a rhexis because any amount of leak from the anterior chamber right now will pull the vitreous into the anterior chamber and my wound. Until now, God has been kind. I've not got any vitreous coming into my wound. Now I just jumped the video slightly again. There I've completed the rhexis. Now I go to do a very, very minimal hydro procedure. Just do a cortical cleaving hydrodissection, making sure I don't give bursts. And now I use the maneuver of tumbling. You must note that I'm using a very graduated tumbling to tumble the nucleus out because I don't want to be chopping in this bag. And the luck has paid out. Patience has paid out. I've scooped the nucleus out of the bag here without disturbing the vitreous. Still, I am lucky. I'm using a very low vacuum and a high phaco. And since I'm a venturi surgeon, so that really helps me to do such cases. Once this is done, now the trick is I have bag here. This is my bag. And I will do a sectorial vitrectomy. Now somebody will say you could have done a pars plana vitrectomy here. Well, I'm an anterior segment surgeon. And I was just discussing this with my retina surgeon that every time I seem to do this, it works for me because I don't dislodge much vitreous. Now what we'll see here is I'm using a cutter. I'm going only in the area, this area, where the zonules are broken and the vitreous is coming out. Only this area. I've not broken the other zonules. Only this patch of zonules were broken where the vitreous was, the anterior face was broken. While my fluid is inflating the bag and not going in this area. I'm using a low bottle height, just done this much of vitrectomy in this area. My cutter has gone in, done a vitrectomy. I pull in viscoelastic. I use hydrocort. I'm just skipping fast. Then put in a CTR to distend the bag again. Now, the moment I put in the CTR, vitrectomy done, we put in the hydrocortisone injection, check for no vitreous in the anterior chamber. The IOL goes in and see, slowly dial. I prefer doing hydrophobic lenses in these patients, single piece, because, and again, the lens haptic is pointing in the direction of maximum subluxation. And now we put carbocol and see how beautifully this patient is doing. Round pupil, bag in the IOL in the bag work perfectly. So this is patience and persistence. This is pre-op. This is post-op. Intuitive observation. This is if you observe well. So I've been seeing some surgeons repair iris. And then I thought that we could have a better method of repairing an iris in a traumatic cataract. This is a case with subluxation and complete iridodialysis here. So I use first, I'll jump the video. First of all, I made a track of scleral path. I make a tunnel. Rather than making a flap, I create a tunnel here, 0.75 millimeter long tunnel. Then I use the railroad technique. First session, I anchor the iris and see how beautifully we use the tunnel technique here. And then I use a shoe stitch technique, the way a shoe cobbler repairs the shoe. So the first anchoring will be done by the railroad technique, very well known. Once this is done, now I will pass the suture through the 26 gauge needle, cut one end. Now I will come out of my tunnel. Once I pull this needle out, I will tie these loose ends. Now once this is done, I thread the thread of this suture through my 26 gauge needle. I bend it by 60 degrees. And now instead of using the railroad, I use my 26 gauge needle in one go to go through the root of the iris and the sclera in one go. You will notice with my left hand, I hold the edge of the tip of the iris And in one go, I thread the needle, and then I pull the loose end of the suture and make a loop. I pull it out, I withdraw the needle again, then I go in again with the same needle. The way you see a shoe cobbler stitch your leather shoe, I'm using the same platform. I'm threading the needle again, coming out, then pulling the loop out. And then once I've done this, all the loops are cut in the center. All I need to do is tie one loop to the next alternate loop, not the next one, but the next one to it. And all sutures will be tied. You can try this by doing with the thread. It works beautifully. So rather than doing a railroad each time with single thrust of 26 gauge needle, I'm going through the iris root and through my tunnel. Now I'm cutting these in the center. The only thing it is you need to remember which loop to tie to what. And once you've done that, now I go to remove the cataract. There's a subluxation, there's slight amount of vitreous there. I do a sectorial vitrectomy as described earlier. I'm jumping the video. And once this is done, I remove the cortex. I put a CTR in using the injector. Once the CTR is in, I do irrigation aspiration, put in the lens. And I don't need to suture a flap because my tunnel, scleral tunnel, is automatically going to close. I just give sutures on the tunnel and close the conjunctiva on top. And this is the patient post-op, 12 days post-operatively. So this is what a calm mind can do. This is last video I'm showing. One of my associates had an Argentinian flag sign. She panicked. She called me to the theater. It was an intumescent cataract. And the block is already gone. So I'm called to the theater. I first attempt to cut this. Then I suddenly realize the interlenticular pressure is very high, that even this is going to extend. So I use my inverted T technique. I pierce the capsule on the opposite side, go in and aspirate the protruding cortex within the area which had gone into the Argentinian phase, where the interlenticular pressure was high. Once I have sucked out that area, I go in and give a cut with the Vannas forceps and again create another T. Now the job is easier. I have T flaps. You just need to be calm. You don't need to be panicky. Just close. And now you can extend the initial cut. And there you go. And finish the case. Put in the lens and you go back happy. Thank you.
One great presentation.
Brilliant.
Great.
Thank you.
Always to watch you. You leave behind remarks till we meet next fight. That's how your memory stays. Abhinav?
Thank you.
Please.
Thank you, sir.
I think this is one of the greatest presentations I've ever seen. One great number of cases.
I had 9 cases, but then I had to limit them.
Then
I think everybody was glued to the screen saying, what are you going to do next?
Kamal, only thing is the inverted T you have demonstrated very nicely in our surgical strikes also couple of times. It is really a wonderful technique. But the problem with the inverted T is only that it takes care of the anterior compartment only. Please understand, in intumescent cataracts, there is a posterior compartment also. And that is where the posterior compartment is wherein the nucleus is bulky and there is pressure in front of the posterior capsule which pushes the nucleus up and produces the Argentina flag sign. Inverted T, the procedure or the technique, you don't take care of the posterior compartment. Whereas my punctorexis takes care of the posterior compartment also. So I always, even now, I prefer my punctorexis for that inverted T. But it's a great technique.
So I'll just answer that. Yes. The moment I make the first aspiration of I make the first puncture, in one puncture I aspirate, I don't give the Vannas cut immediately. Then I go in with viscoelastic on the opposite pole and push, do a steamroller effect of the viscoelastic, anterior capsule being flattened. The capsule rexis now pushes the nucleus down and you can actually see more fluid coming out of the linear cut. Once that is done, only then I give a cut in with the Vannas. So if you want, I can go back on the video. I push viscoelastic and it pushes more fluid out. So it pushes the nucleus downwards and pushes more fluid. Once the interlenticular pressure goes down, even if there is some fluid behind the nucleus, I have never seen, sir, more than 474 cases done Never seen an extension. I have recorded all 474.
Dr.
We are
Rohit,
publishing
can I
it
have
now.
your comments?
I think it's a perfectly shown video. And I think Dr. Kamal needs to present it in some journal. The publication has to be there.
I'm doing that. Thank you, Dr. Rohit. You gave me an idea. I'm working now.
Yeah, I think hats off to you.
Dr. Deepak?
Hello. First of all, congratulations to all the speakers, Dr. Kamal Kapoor, and Dr. Rajan sir, Dr. Arup sir. For Dr. Rajan, I must say I am the regular user of one of his choppers, the Rajan choppers. This is for the attendees. Must try this chopper. The second comment I want to make is regarding the Dr. Rajan's technique, regarding the number 11 blade. I'll just add one micro point to it, that I use artery forceps. Whenever we have encountered this problem, we take the 11 number, that's all right. But when we make a cut, we just jab then artery within the cut. It will open the cartridge and you can take out, release the entangled haptic. The third point, the third thing I wish to mention for the attendees is there are two different things. One is decreasing the intralenticular pressure and making the CCC. Please disengage these two things. These two things, because we are trying to do CCC, then we say the pressure was high and the CCC has gone out. These two things have to be separated. Decreasing the intralenticular pressure by whatever, you may follow a double CCC, you may follow Dr. Kamal Kapoor's technique, you may take a needle, just decrease the intralenticular pressure, then do a smaller. My technique is I do a smaller one and then I do a bigger one. Though
great,
my
Deepak.
boss, Dr. Bharat, doesn't agree to this because it wastes time and he's more quick than me, but I feel I want to go safe, so I do two. Another point I wish to mention is that one is, I think Dr. Mohan Rajan has mentioned, is to just take a punch, make a punch with the phaco and make a circular opening with the CCC. Another technique is doing the yak before surgery. Then there was another innovation, that was to use a needle cystotome. Just like a sewing needle, you make punctures. It is a micro CCCs. I believe I have never used it, but I found this was presented in Indore. But I found that this was really, really a great innovation. We can make small punctures in the CCC in the anterior capsule, and there are small circular openings, and then you can join them. There is no way. I have worked in Delhi. I have even done femto cataract, but I feel that this needle cystotome is much better. Thank you very much.
Thank you, Deepak. Thank you very much. So good at
Nice inputs.
Thank you. Good ideas. Now I have the privilege to introduce my young friend, Rohit.
Oh, thank you for calling me young, sir.
Then I'm the youngest.
I was a great admirer of his father, Dr. Om Prakash, who could not have been. Anyone who knows him will only learn how to work hard. He was one of the persons who probably was first to do maximum number of the IOLs in the posterior chamber in this part of the world. I may name as whole Asia. But Rohit has brought that name very much above and to a level. Of course, now the technology is very advanced, Rohit. You're not lucky. That time this technology was not there that you could rule the world by sitting at home. And to introduce him, he has a third generation of ophthalmology into his hospital. He has published innumerable new techniques, an innovative, simple, very polite, very on-to-point surgeon. Simple techniques like how to stay in a trip and blue, IL scaffold, and the greatest of all, the flap mortality sign has won him laurels and awards at international levels. Abhinav, kindly introduce Dr. Rohit for the next topic. Okay, Rohit, we start with you.
Thank you, Dr. Dhami, for the kind words. So I would be talking about, my small ventures into subluxated cataract. So am I clear now?
You are.
Yes, sir. Yes, Rohit, you are clear.
Yeah. So subluxated cataracts is something which I'm going to talk about. This is a video. Just 1 second. Let me move this to this side. Yeah. Now I'm ready. So now this is a video in which you will find that it's a black cataract, and you will find there is a fibrotic sheet in the anterior capsule here. There is a broad iridectomy sort of thing which has been done. The sutures which were applied maybe some donkey years back, and you can see a black cataract there. So my plan was, how I started was, I start the rexus farthest as I can from the place of zonular dehiscence. The incision is also aptly planned away from the area of zonular dehiscence. I would have liked to make a large rexus, but I thought I would be away from that, and you will find there's a fibrotic sheet which is being taken care of by me. And these fibrotic sheets, even if it extends later on, they rarely extend beyond the equator. The fibrotic sheet doesn't let them usually extend. Once that is done, the next thing which comes in is the capsular hooks. I always use capsular hooks for quite some time now. After using the capsular hooks, because these capsular hooks provide me three things. They act as artificial zonules all the way, number one, and then they immobilize the bag, number two. They provide an antero-posterior capsular support in all these patients. The next was the nuclear emulsification. I thought I would be doing, because this was a very hard cataract. So by all means, I did not introduce a CTR at this point of time, because I thought that the hard nuclear fragments, by their firm volume, would act as an internal scaffold for that matter. The bag is left there, and you will find that I'm taking out the hard nuclear core. The bag is totally inflated with the capsular hooks and with the hard nuclear fragments for that matter. Once that part is done, I then move on to remove the nuclear fragments. The key is make large nuclear fragments, rather small, multiple nuclear fragments, separate them totally, leave them in situ, and then once you have totally separated all these nuclear fragments, the nucleus pieces are brought in and they are emulsified for that matter. So this is what the way which I went ahead. So at this point of time, I was worried about the flaccid posterior capsule too. So for that, at this point, when the last nuclear piece was to be emulsified, I introduced the CTR. I introduced the CTR usually by, just by dialing it in. And at this point of time, with that there, then the Amar scaffold comes. I call it the Dr. Amar Agarwal scaffold. I push in a multi-piece IOL, and then with the multi-piece IOL, I just dial it, place it in with the McPherson, as you will find how I did it. So with this, now I am working at a deeper plane with the IOL acting as a scaffold. And once that thing is done, now the capsular hooks have been taken out. Now I will go in with a single pass 4-throw pupilloplasty. So this is being done. You go in from the other one. Once that is in, use the forceps to your advantage to hold the iris. It should not be a degenerated iris for that matter. And then railroad it in. Once it is railroaded, take it out. Once that is taken out, now go through you'll see how it has been taken out. Now I go through and with the Sinski, bring it so that I form a loop. And then I use the other forceps to just pull it out. Here it goes in. And now once that is in, here you will see how I am catching it. It's an unedited one. Now the 4 throws have been taken care of, and the pupil becomes slightly circular. I'll again go in. Yeah, it's being cut now with these scissors, micro scissors for that matter. You can use any as per your convenience. You can use an illuminator to see whether you are there at the right place, not cutting the the knot itself, because at times that itself can create a problem. So now that is being done. You will find how. So with this, the second, so that the pupil is perfectly formed, I would like you to see that here, you have to center the pupil also, these Purkinje images. So for that, I'll do some sphincterotomy so that the Purkinje images are right at the place and the pupil is formed in the right manner. See how it is being brought, and then you hold it to bring it out, and then you can use those 4 throws. 1, then you'll go in for the second. I think Dr. Amar took this pupilloplasty to the ultimate level, because sepsellar knots were also always there. Now it is being done. Now at the end, I would be creating the pupil coinciding with the Purkinje images. Here, I would like you to see that there is 180-degree subluxation here. So in these patients, the site of incision is already away, not directly over the area of subluxation. Rexis initiated, away. Capsulorhexis completed. You have to center the lens, and you have not to center the pupil. So the lens has been centered, and the capsulorhexis adequately completed. It would be slightly oval at this point of time. I am a strong user of capsular hooks. I will use 3 capsular hooks in the area of zonular dehiscence, and I will use nuclear pieces as internal scaffold and delay the insertion of CTR. In the next case, I'll be inserting the CTR right at the upfront. After inserting the capsular hooks, you can see how easily we can rotate because of the artificial zonules which the capsular hooks are mimicking. Total chopping, separation at different multi-level chopping. See how I'm going to realign the nuclear fragments in the area of zonular dehiscence. And when I'm doing that, there are 2 scaffolds now, 2 supports. One is the capsular hook, and the other is the internal adjunct in the form of hard nuclear fragments. Mark my words, if these fragments happen to be soft, you cannot use them as internal adjunct as a nuclear scaffold. So having a hard nuclear fragment is obligatory and mandatory for that matter, because that way you can delay the insertion of capsular tension rings. Now, when I see that the last piece is around there, so at this point of time, I introduce the CTR, and then, see where I'm placing the spatula. It is placed behind so that it takes care. Then, this is something which I should have done early on. Mark my words, you should always create this at the start of the surgery and not the way I did it, because at that point of time, the globe is hard. Now the CTS is coming in. Once the CTS is there, we will find that I'll just railroad it in, and I'll just rush over it. The second will also come, and After that, the lens will be implanted in the bag, and you will find that the lens is perfectly centered. This is the third case. You will find that there is zonular dehiscence more around 180 degree or more. The site of incision here is also very, very important. It should not be directly over the area of zonular dehiscence. So that being done, I use what Dr. Thind uses, the Wong's supraincisional pocket in all my cases, visco-dispersive and visco-cohesive afterwards, or you can use only visco-adaptive away from the site of, the direction of the initiation should not be in this direction. It should be in this direction so that you put less stress on the zonule. So I'll be committing a few mistakes, which I'll tell how these things should not have been done. So once that is gripped, I'm moving around, making a capsulorhexis. So this is a lens with more than 180 degree. So at this point of time, when I have to move my capsulorhexis in this direction, so I thought that I need a support. And what is that support going to be? I'm going to introduce the capsular hooks at this point of time. So these capsular hooks will provide me with additional support, because that will immobilize the bag. Once that immobilization of the bag has been done, in this situation, what I will do is, now I will complete the rhexis. This rhexis is being completed with the help of these capsular hooks. Now the fourth capsular hook is going to be introduced. Another point, now you will find that there are areas, this area and this area, where there is a lot of scope for the capsule to get injured during the emulsification procedure. So at this point, I will add a CTR up front. So this CTR will help me form the bag at this point of time. So now I'm waiting for the I'm doing the hydrodissection, minimal, away from the site of the zonular dehiscence. And now I'm going to add the CTR. So I'm going to use it from the area where the zonules are intact, and I'll move it on to the area where the zonules are not intact. So this was the way I did it. If somebody can tell me how differently I could have done it, I thought at this point of time, had I done it like this, it would have been better. But that was a retrospection. But because this is going anti-clockwise, had I done it clockwise, it would have been better. So, but still, I was able to place the CTR in the bag up front, not waiting for the nucleus to act as a scaffold, because there was a much larger area of zonular dehiscence. So now when that is done, you will find it is perfectly dialed in. You can see the other eye going in. So now, once that is done, the next step is the nuclear emulsification. Chop it into different pieces. Yeah. Now, after that, again chopping, keeping them in situ, continuing, and then I'm just dividing them, chopping them into small nuclear fragments. So once that is done, then only I start taking it out. Now you will find that I'm doing something more which is suboptimal. I will be, I should not, you just see, I'm not using the nuclear pieces as scaffold. As a matter of fact, I should have moved this all around, brought this nuclear piece here, and then chopped it, because that would have further given support to the capsular bag with the nuclear fragments stenting up the capsular bag all the way. So now with that done, so this is which I retrospectively, I thought that I should have used the nuclear fragments as a scaffold. So this is how I'm continuing. So this, managing these subluxated cataracts is an ever evolving technique. And you always improve with discussions. You will see how easily that is being rotated, dividing into small fragments and emulsifying it at the level of the anterior capsule or maybe slightly more anteriorly. So with this done, I inflated the bag again. This was inflated so that to give further support, to further stent up the capsular bag to the fornices. I'm using the straight spatula to keep the posterior capsule behind all the way so that the flaccid capsule may not come forward. The tangential stripping is the most important thing. Dr. Mohan didn't talk about, taking it because he only taught me how to do the, when you are not able to do it, hold the cortical lamella from near the posterior capsule and with low vacuum, bring it forward and aspirate it. But that was not required here. And I could easily complete the, the cortical cleaning in this patient. A bi-manual irrigation aspiration could also have been used because that would have made different planes of irrigation. And this is another mistake I did. I should have put an intraocular lens at this point of time. And after putting an intraocular lens, then only I should have moved ahead. But I moved ahead because I thought that a good job had been done. And I just use a multi-piece lenses in these patients because I feel they provide a better opening up of the capsular fornices. So once that is done, a CTS was placed and the surgery was completed. Thank you very much for your kind attention. I think I overshot the time for that matter.
Beautiful presentation, Rohit.
Very good.
Very nice.
Very nicely and very nicely, elaborately taken points.
Very lucid, Dr. Rohit. Dr. Rohit,
Very nice.
as lucid as ever. Amazing clarity, amazing concepts, and the way you put it across for all beginners, I think there's a lot to take back home.
Very nice. See, I think I want to just raise one point, Dhami.
Yes.
Rohit has beautifully mentioned whatever mistakes I have done. Please understand this, when you have a capsular bag or any subluxation, please use capsular hooks for that. You have the David Chang's modification of the capsular hooks, which are even smaller, so that you can even introduce a CTR and you will not have any problem while cortical removal. Cortex removal, there was a question about cortex removal in the presence of a CTR. You can go engage the posterior lip of the cortex and you have to go tangentially along the circumference of the equator instead of coming radially, which normally you do when you don't have a CTR. When you have a CTR, you have to go tangentially and then come, and if you go for a few clock hours and then come radially, all the cortex will come out very easily, even in the presence of a CTR. I think all the aspects have been beautifully covered by Rohit Om Prakash.
Very good. Very nice. Yeah. Dr. Kamal, your comments? Kamal is out. I think
temporarily out, yes.
Actually, one point, Mohan, I'd like to ask for everyone.
Yes.
Is the inserting of CTR?
I can hear you. My bandwidth is giving me trouble.
Okay.
Yes, boss.
Okay.
My bad. I think the concept of removing the cortex after putting the CTR is definitely tricky, but there are new kind of CTR rings which are called the Henderson's rings. I've not used them, but they have undulations on their side. So which it's not a complete ring, it has got up and down bevels on them.
Yeah,
so you can remove cortex from that. I've not used them, but they really seem to be helping, I guess.
Any problem in inserting them?
No, they just go in like a normal CTR.
That's good.
I think Dr. Mohan has come out, his... Mohan has come out with a very good click in the whole thing, that you go from the fix the posterior cortex, which is on the posterior capsule with a low vacuum, then increase it. I think that click really works all the time.
Absolutely. Similarly, in a femto also. In a femto also, you have problem while removing the cortex because it cuts the cortex straight. So I always go posteriorly. That is, I try to go posteriorly and try to remove the cortex when in the case of a femto case. So that makes life a little more easy. Only thing is you have to be a little careful. Don't use very high vacuum. Don't use very high aspiration flow rate. Okay? And make sure, because you are very close to the posterior capsule, they can have a problem.
So there are 2 points I would like to highlight here. So number one is the interplay of the OVDs. I would prefer to use a sideways soft shell in these cases, in the areas of the zonular dialysis, zonular dehiscence, where the viscoat is pushed in and then you put either a viscoadaptive or a high quality cohesive OVD. Number one. Second thing is, when you do that, if you try to stain the anterior capsular trap and blue dye, it is very unlikely for the dye to migrate to the posterior segment. And it is, I think, important to stain the capsules in these cases because you have to engage the iris, the capsular hooks or the iris hooks to the rexis margin, and sometimes the surgeries may be a little prolonged. The corneal, it may be a little hazy. So I think staining the anterior capsule, I would prefer to do as many times as possible, and then use the OVD in a sideways soft shell. And I would like to keep the bag inflated with the dispersive OVD all the time, because even if we use the capsular hooks to stretch to support the rexis margin, in between the capsular fornix keep collapsing in. So you have a lot of dispersive OVD there, and it has to be refilled several times. And third thing is, Dr. Rohit, wonderful videos. Would you just highlight a little bit about the phaco parameters settings that we will be modulating in these cases than the routine?
So obviously, we have to, basically we have to realize if we use high parameters, that will not be conducive for 2 things. First is it will aspirate the visco, number one. Number two, the chamber will be unstable and there will be more stress on the zonule. So you have to have stable chamber settings, low fluid parameters to take care of all these things.
That's good.
Absolutely. Low aspiration flow rate.
Yeah.
Make sure that when you have viscoat or when you have a PC tear, when you have viscoat, you don't want the viscoat to come out of the eye. So always make sure that your aspiration flow rate comes down. I use as less as 20 or 22 ml per minute.
So what would be your IOP in those cases? In this case, I thought 36. Would you like to come below this, or would you like to go a little above this?
I keep it around 35 to 40.
I have not gone below 30 by any means, because
I'll just add, I am a Venturi user, so I just play around slightly with my bottle height in some situations. I would just get the bottle height to around 85, 90 instead of 110, and just lower my vacuum from 320 to 260, and it works fantastic.
I think 36 IOP is a very good idea, because sometimes you tend to come down thinking that there is open area of the zonules and fluid is going to get misdirected. But I think if you try to reduce the pressure to less than 30, 35, 36, as you have done, I mean, you have used the right pressure, the AC maintenance becomes difficult. And then, you have repeated prolapse, surge, and things happen. So I think 35 to 40 would be the ideal IOP, at least what I would do in my case.
That's what I also
believe,
do.
Rajan,
I use
have a
the
comment.
Centurion. Yeah.
Yeah, these all our honored speakers are users of Centurion, and people who use J&J and go by the rule of bottle height, nowadays a medium bottle height up to about 65 to 70 centimeters does a good, valuable, viable IOP in the anterior chamber. And all our parameters are linear. A good foot control, a good eye on your phaco tip will do justice when you are not modulating your aspiration or power.
I would just say, Dr. Dhami, that it's always a good idea to be on a linear situation than a panel, especially when doing tricky cases, because then your foot knows what it has to do.
Yeah, we are always on linear. I think it's always better to be on linear. But then your foot pedal is speeding or not speeding to remove the fragments.
Absolutely.
I think we advocate panel only for the beginners, when they are not very sure about their foot pedal position, because they tend to use a lower power to start when they learn in the initial days of the learning curve. But linear control for everything, I think, is
better on the foot switch. Yes.
Abhinav, any questions from the Oh, we had a wonderful session, and now I request Mrs. Bora, our Vice President, pause to say to conclude the remarks of this session.
Thank you, Dr. Dhami, for having such a wonderful webinar. And I think this was one of the best webinars. And can you hear me?
Oh, yes.
Yes, madam.
Okay. So I think this could have been this has been the best webinar and the best utilization of this has been the best utilization of Sunday morning. So I want to thank Dr. Dhami for
I think Dr. Dhami has set the bar
having
very
such
high.
a good webinar, and that's been really nice. And all the speakers, Dr. Mohan Rajan, he makes everything seem like takes everything with such a sense of humor, so that everything seems to be so easy. And he's such a wonderful speaker and a wonderful person. And Dr. Arup, I know he's been teaching all the ophthalmologists, and he's been giving his skills to all the new ophthalmologists and even the experienced ones. And Dr. Kamal Kapoor, yes, so many rabbits in your hat. And it's really, really good. All the rabbits under the hat and of course under the turbans in Punjab. And it's been really good and very nice. We've all thoroughly enjoyed and I'm sure everybody's made best use of a Sunday morning. And Dr. Rohit, you are simply wonderful. I've been to his OT, and his OT is so calm and quiet. It gives you the vibes of so much of calmness, and he's working, like there's a saying, like a duck, paddling underneath and being very calm on the surface. That's what Dr. Rohit is. He's a wonderful person and a wonderful human being, and of course a wonderful surgeon. And even my sons, they go to him for advice, and he's really wonderful. And overall, this has been such a very nice webinar. And Dr. Dhami, thank you so much for making us all make so much use of a very good use of Sunday morning.
Thank you,
And
Mrs. Bora.
Thank you, everyone.
Thank you very much,
Dr.
madam.
Ashwini, you would like to say a word?
Thanks a lot, ma'am.
Ashwini?
Dr. Dhami?
Yeah.
Dr. Dhami?
Oh, yes.
What I've done is my signal was low, so I've driven down to my center right across and
I was enjoying. I thought, I wish you make your mobile horizontal. You give us a bigger view.
I just walked into my center to drive down because the signal at my home was tripping. So I have one center which is nearly 1 kilometer from my home. So I just drove down, called the guard to open it. So now I'm again on a broadband lease line. Now I can beam any speed of videos you want.
Very nice.
That's great. That's great. Dr. Ashwini, a few words.
It was an excellent webinar on behalf of President POS, Dr. Shkeen Singh. I thank all the speakers, Dr. Arup, Dr. Mohan Rajan, Dr. Kamal Kapoor, Dr. Rohit Prakash, for their valuable time. It was since we were already sitting in homes, there was no take-home messages, but many in-home messages we got, and all the attendees also got many in-home messages. So that was an excellent. Thank you all.
Thank you.
Dr. Dhami, Dr. P.S. Rana, and LOS for arranging this webinar.
Wonderful,
Dr.
Dr.
Rana,
Dhami.
your word of thanks.
Yeah. Can you hear me?
Yeah.
Yes.
I will first like to salute the warriors. I mean, not only the Corona warriors, but you are the one who overcame worst scenarios. So you all are warriors par excellence. So Dr. Mohan Rajan is very articulate, and his videos have always a good take-home message. So apart from being an excellent surgeon, he is an excellent teacher also. I thank him for showing us a way to tackle a situation in which we are all scared of. Dr. Arup has shown us cases which look very easy in his hand, and I think after his presentation, we can go after these cases confidently. I would like to thank Dr. Rohit Prakash, who is an excellent surgeon. He proves that bold is beautiful. Dr. Kamal Kapoor is a glamour boy of ophthalmology. and he is equally deft in his surgery. I would like to thank him for showing us a way to do things differently. On behalf of Ludhiana Ophthalmological Society, I would also like to thank Dr. Dhami and his team, who made great efforts for arranging this webinar. Last but not the least, I would like to thank Bhushan and all the listeners and the team for arranging this webinar. Thank you. Thank you very much.
Dr. Dinesh,
Dr.
words
Dhami.
from you.
Thank you. Thanks a lot,
Deepak,
sir. It
you
was
have an
very
announcement?
nice. I think when experts say that I made this mistake and this is something which you should not do, I think that is the best use of time. And I appreciate Dr. Rohit, Dr. Kamal Kapoor, Dr. Arup, and Dr. Mohan Rajan sharing their difficult scenarios. I won't say worst scenarios, as he says, the worst is yet to come and best is again just yet to come. So they're difficult scenarios. These were difficult cases, and there's a lot to learn from the top surgeons of the fraternity.
Dr. Karamjit,
Thanks
are
a
you
lot,
around?
Dr. Dhami and Dhami Eye Care for arranging and giving us an opportunity to learn.
Thank you,
sir.
Dinesh. Dr. Karamjit, are you around?
Hello, thank you, sir. Actually, my video is not, I think, visible because
your
of
audio
some
is there.
technical problem from my side. I attended a whole webinar. Am I audible, sir?
Oh, yes. Oh,
Yes,
yes.
sir. Very much audible, sir.
Excellent presentations by excellent speakers. Thank you, Dr. Dhami, for organizing such a good and informative webinar. Sorry that my video is not visible.
No
Somehow
problems.
I contacted
No problems.
so many times. But I attended the whole this webinar. Congrats, Team Ludhiana Ophthalmological Society for such a wonderful
Dr. Chekithan,
Thank you.
your words, please.
Thank you very much, sir. It was an honor to attend a great webinar, and I was enlightened by the great speakers, starting from Dr. Mohan Rajan, who's also SN alumni. I am SN alumni too, and Dr. Dinesh, and Dr.
Thank you,
Kamal
Chekithan.
Kapoor. Thank you, sir. And Dr. Kamal Kapoor, Dr. Rohit Om Prakash. It was great to see, and it inspires us to do many more things in the future. We are equipped, and I think all the people who attended must have been benefited. Thank you so much.
Dr. Rohit, we have a seminar, we have a webinar. I'd like to make an announcement.
Yeah. We have a webinar in the evening, 6:30 p.m. That is on capsular challenges, wherein different surgeons would get into explaining the different, capsular challenges which they come across in their lives. So can I share my video to show what all is going to be there?
Please do.
If I'm permitted.
You are.
Yes. It's a very interesting webinar.
Yeah, it's an international webinar.
I know, interesting.
Yeah. Can you see it now?
Now you'll have to share your screen.
Sorry.
Dhami, I would like to thank you for the wonderful opportunity.
Thank you.
Always, it's a pleasure to come back, to Punjab, and to your place.
So this is basically, we have panelists. Dr. Dhami is there, Dr. Mahipal Sachdev, Dr. Namrata Sharma, John Hart, Joshua Young, George Biko. Then we have Partha Biswas, Deepak Magur, Rajendra Prasad. We have speakers as Professor Chisoon Fake, Dr. Abhay Vasavra, Ashwin Agarwal, Matthew Paravella, Lisa, the great Lisa. Shiraz is also there, Shiraz there. And then Naveen is there, Dr. Naveen Rao, and Tushya is also there. So it's going to be a highly interactive session, and let's see how it comes up. Thank you very much.
That's good, Rohit. We wish you the best. Deepak,
All the best, Rohit, for that.
Yeah, thank you, sir. Thank you.
Yeah. Dhami, thanks a lot.
Okay, see you.
We meet
Thank
again
you,
soon.
Dr. Dhami.
Thank you,
Thank you,
thank
Dr.
you,
Dhami.
Dr. Dhami. That was
Thanks
wonderful.
everybody. Kamal, Arup, Nikitan, Deepak,
Arup, thank you.
Dinesh.
Thank you, sir.
Thank you. Doctor,
Dhami, that was
thank you, Dr. Dhami
wonderful,
and the whole team.
wonderful seminar,
Madam.
webinar.
Okay.